Nicola, can you sum up for us what are the advantages of an integrated system like you have in Cortona?
Yes. For us, in this surgery, and we are very happy for our job.
Okay, now is in position. This is yes, now
You can see the marker.
marker.
You know, one thing that came up just now, we were talking, how many folks here with toric lenses go and clean their viscoelastic underneath the lens?
Yes, of course.
Right? Meant to decrease the rate of rotation.
I think it's very, very important. With also the prevention of post-op hypotony, in my opinion, that can turn the IOL. So, wonderful. It's a sign of destiny.
Okay. The lens in position.
Any question?
Andrea, non sta funzionando, per cui noi forse andremo avanti con le comunicazioni. Io proporrei.
We are the surgery is the end. In the little section.
Ok, perfect.
Thank you for your attention.
Perfect, Andrea. Good job. So, let's go on a particular session on challenges cases in lamellar keratoplasty. That is very, very important because each of us can have to manage cases like this. And so I invite Sophie Deng, management of endothelial failure in complex eyes, the MEC versus the SEC. And this is a very important point, in my opinion, how to choose the one or the other.
So thank you so much for this very nice surgery. Again, we're going to switch gear. We're not going to talk about premium IOLs and normal cornea. We'll talk about the worst cornea they're going to see. And since 2017, after the report from the Ophthalmic Technology Assessment from the American Academy of Ophthalmology on the safety and outcomes of DMAC, then DMAC become the preferred choice of EKs in uncomplicated eyes like Fuchs and more of the eyes with normal anterior segment. And the go-to techniques I do here is a single cannular, non-touch, touch but no touch technique. It's very simple and technique to accomplish unfolding. But however, how about on those eyes that are not as straightforward? For example, eyes with prior retractomy, traps, shunts, failed PK or DSEC, and eyes with extensive anterior scenic hair and very severe corneal edema. Also, those eyes unicameral, like the eyes with ACLL or AFib. What should be the choice? For me, technically, you can do DMAC in all of these eyes. Is not the issue. However, in terms of long-term outcome, I still believe that DSEC will do better in unicameral eyes like ACLL and AFib. So how to do this EK in these such eyes? First of all, you need to prepare the eye for the graft, right? So to create space and the anterior treatment by lysis of anterior scenic hair, trim the shunts, and then the key thing for this eye is how to control the anterior chamber depth. Also in eyes really severe edema, you have to increase the visualization so you can see the orientation of the graph. And lastly is the management of the air. So this is my go-to techniques to tell the orientation of the graph, which is really simple. Use one single camera, go inside the eye and sweep left and right if the graph is in correct orientation, and the camera can go inside the scroll, right? But if it's upside down graph, no matter how you sweep left and right, the camera will not turn blue because it's upside down. So how to create the anterior segment like chamber like this? I have two shunts. So the intraocular scissor is very, very handy to, I don't know why it doesn't show, but the other one is a SICSSO to stabilize the shunt and then trimmed it. And it's very simple, it takes about like 30 seconds to do so. Then in eyes with extensive anterior scenic care, such as this eye, that has undergone 7 surgeries, there's literally no anterior chamber. So to do that, you have to lyse adhesion, so to form the anterior chamber. And often these eyes has very thick fibrosis. So scissors might be necessary to remove those fibrotic tissue. I just want to show you how that is done. You see, very thick, it's only a small fraction of it. It's a very thick fibrous tissue. And again, iris is very, very vascular tissue, so often you encounter this kind of bleeding, which is extreme. So that I become able to have femur, and I have to wait for 20 minutes in order for it to settle down, and then I use anterior vitrectomy to clear the clot, because make sure you don't make it rebleed again. And afterwards, use the standard technique to do your DMAC in this case. So even though before the surgery, this eye, okay, again, you see this blue Canada sign, and you can see that the graph is correct orientation while I'm unfolding the tissue. So how about in eyes with really poor anterior visualization, such as this eye, which had undergone multiple retinal surgery, and these eyes, you can do a DMAC. One way to increase visualization is by removing the epithelium, and sometimes this eye, it didn't make any difference. So use light pipe, which is really handy, simple method to use to visualize the eye. And this eye had a really thick retrocornea membrane, and so that with this visualization, you can see that we can remove the this membrane in one single piece. And after that, you do your regular DMAC surgery, and the light pipe again can help you to look at the orientation first before you unfold the tissue. And again, I like to use my single Canada technique. You see, when I get inside the scroll, you can see the blue Canada sign, and I know exactly what orientation is. So I don't need to have any marking on this cornea, and sometimes marking doesn't work really well because visualization is so poor, you just can't see it. In this case, I evidently ingest some air bubble, so I use this as a tool to unfold the tissue, just by gently stripping this air bubble to unfold it. Because this is post-vitrectomy eyes, the ACE is extremely deep, so one hand I hold down the tissue, another hand I unfold the tissue. Okay, so and this way that you can unfold the tissue pretty easily. Again, because this is a post-vitrectomy eye, in order to stabilize the anterior chamber, you use a curved type to artificially shallow the AC and keep it shallow so that it doesn't scroll back the tissue, and then use a cannula to flow the tissue onto the cornea. So and in DSEC, these are my two go-to techniques. Oops. Can I reverse back if I can? Can you show the video on the left? But anyway, so the two very simple techniques are also very cost-effective technique is use 30 gauge needle to push the tissue, and then the other one is to use a 9/0 Prolene suture on the right side. What you do is you fold the tissue in the inside, and then push the needle through the stroma, and then suture onto the cornea. And this way that, especially in a phakic eyes, and they will skewer the graft on the cornea without dislocating it. So this is a really good, secure way to do a SICSSO surgery in very complex eyes. Unfortunately, the video is not going to play for me. So the last thing I want to mention is that before you put any air in this eye, you have to pressurize the eye with, I don't know what it's doing. Can we advance that one if you can? But air management is very important. Pressurize eye before you inject the air, so the air will not go behind the iris and push forward to your cornea and then give you nightmares. So in summary, is that in such eyes you can do a DMAC, or you prefer to do a DSEC. It's totally doable. It's better a matter of how your confidence or your experience and how you think that will be the patient will do better in the long run. So thank you everyone for your attention.
Thank you for your wonderful presentation. Anyway, I would like to briefly ask what to add.
A couple of comments. I think that it's important to recognize your ability with DMEC and with the SAY, and how much trauma to the tissue there will be in different situations. So the other aspect is the bubble support. With DMEC surgery, we know from all the articles that we need a prolonged bubble support. That's why most of us use gas rather than air, because we want to have a long time bubble support. I mentioned in my talk this morning that with the SAIC, you only need 1 hour of bubble support if you've done peripheral scraping. And because of that, with eyes that are aphakic or eyes that have hyperfiltration and the bubble will be gone when the patient sits up, I do it to SAIC because I leave them flat for an hour or two, and when they sit up, there's no bubble support, but the tissue will stay attached. With the DMEC, not so much.
Great cases, Sophie. Excellent. I think what the presentation was short and couldn't show all of the patients that you have during these cases, which is waiting for the cornea to dry. So putting the bubble, and then I just sit around for many minutes without putting any BSS, especially in these complex eyes, and I just add more air bubble. Usually I do not use SF6 unless I have to, or it's a rebubble or reoperation, because being patient and drying the cornea does the job.
Enoxaparin in the presence of fibrin.
Well, we use it all the time.
All the time.
We use it as part
soaking the graft in the.
No, we basically put the 40 milligram in the bottle, and every bit of fluid used is from that bottle. And it's helped, especially since we have fellows. Especially when they're starting out, the surgeries are longer. There's definitely more chance they're going to hit something. A lot of our patients are on these newer anticoagulants. They don't seem to help. So since having done that, it's probably been about a year. Much less, trauma to my cardiac tissue, but also we haven't had any fibrin, even when there's some heme that doesn't seem to be as much a problem. And anecdotally, but I can't say it's as much, the grafts maybe unroll a bit better. That's the only thing, but we use that for all those cases. That said, for any complex case, we used to say, DMAC everything, and we've kind of come around. Vitrectomized, aphakic. Even I do a lot of anterior sclerofixated lenses. All of those are going to be
Yes, we see. Yes.
I think the main question here, besides the eye condition, is the ability of the surgeon to conduct the case. And there is nothing worse than to be in a complex case that you are going to go to do a DMAC and you think, oh, I should have done a DMAC.
Yes. Not a regret.
Yeah, so it's very based on the experience of the surgeon.
Let's go on with a small change in our list. Please, wait a moment. Dalia Said asked to participate and talk. Please, Dalia. Dalk in patient with deep scars and previous items.
Thank you very much. Thank you for the invitation. So I'd like to acknowledge Professor Habib Natua, who's taught me most of what I know about DALK, the goal of deep anterior lamellar keratoplasty, I have no financial interest to disclose. So when your patient has had previous hydropes, would you actually do a DALC? I would, especially if he's severely atopic, obviously he has steroid responders, but I would definitely counsel the patient and tell him that he's going to end up with a scar, and if the scar is in the visual axis, it will affect the vision. So it's really important in these patients with deep scars to do an OCT and actually find out whether it is a deep scar or the patient had had previous hydropes, like in this case. If the patient had hydropes, then I wouldn't attempt a bubble because you're not going to get a bubble. But in deep scars, you can, and you will get most of the time a type 2 bubble. So you really need to be able to manage these type 2 bubbles because there are quite a lot of tricks with them. So like in this case, you can have a very nice clear type 2 bubble extending right to the periphery of the limbus. It is very important to put a small air bubble in the AC because that is what tells you when you de-roof the big bubble. Like here, my brave slash was not very brave initially, like in this case, but only when I did a proper brave slash and the small bubble in the AC moved, I knew that I had de-roofed the type 2 bubble and I can complete my surgery successfully. Now, sometimes things are not so clear. Like in this patient with deep scar, you inject the air, you don't know really is there a big bubble or not, but the AC is very tense, so I assumed I have a big bubble. So I did a paracentesis, and I could see probably because of the small air bubble in the AC that I actually have a partial type 2 big bubble. And here you can put the healer and open the bubble and de-roof the bubble and continue with your operation, and you're able to complete the surgery successfully. Now, opening of the bubble can be a challenge. See, this patient is very, very tricky. So we injected the air, can't see much, there is a scar, there is the air, and suddenly there is that sudden gush of air into the AC, and you will see it here right at the periphery. That's the edge of the type 2 bubble. Now look at my mistake while I'm opening, de-roofing the bubble. My paracentesis was actually not very peripheral. So it is a bit central. Look what happens to the type 2 bubble. So my paracentesis actually nicked the bubble completely, and I lost the bubble because my paracentesis incision was not peripheral enough. You have to be very careful with type 2 bubbles that your paracentesis has to be vertical and really very peripheral. And then you can get a double chamber like this, and then you're not very successful. Now, type 2 bubble is a very, very fragile bubble. So even with very little maneuver, it can rupture. Like here, we got a type 2 bubble. Now, the mistake was I forgot to do a paracentesis. And when you forget to do a paracentesis, the type 2 bubble is under a lot of pressure, especially if some of the air escapes and you even have another bubble in the AC. So look what happens when I was trying to de-roof the bubble. When I'm trying to do the de-roof the bubble, look at where with my wave slash, look at the type 2 bubble ruptured and the fluid gushed inside the air bubble, and I ended up losing my DALC. And this is the area where it's ruptured. Now, in deep scars, you may get a small type 1 bubble. Now, the trick is do not try and extend this bubble because this bubble could be limited by the edge of the scar. So if you get a small type 1 bubble, be careful, try and de-roof the bubble. In this case, the air bubble opened prematurely. So this is the preferred technique in these deep scars. You hydrate the whole cornea after you aerate it. You have very good visualization. The stromal lamellae are separated from each other, so you can completely remove most of the layers of the cornea. And even if you leave a little bit of scar, especially if it is off-center, the patient can end up with very good results and a very successful DALC. And if you get peripheral tears like this one or that one, you still can have very successful DALCs if it's 1 or 2 quadrants in the periphery. If you are doing a viscodissection and you get intrastromal big bubble, remember some of the viscoelastic may escape, and you may not be able to completely remove the stromal lamellae with the viscoelastic, and you will end up with a scar like this. So be careful when you're using viscoelastic. I'm just going to finish up by this patient where we did a lamellar anterior lamellar keratoplasty in a patient with actual acute hydropes with repeated perforations with an underlying vasculitis. So because of multiple glues didn't work, so we went and did a periotomy and removed all the blood vessels and all the scar tissue like here. Then we did a lamellar dissection of the sclerocorneal button over an anterior chamber like this. So you set up to the depth you want and use the Melis dissector like the old technique of doing D-sex, and you dissect limbus to limbus, all your cornea. Then after that, you can use a template to decide on the area where you want to actually put your graft, and then you can just use a 15-degree blade to cut the sclera, and immediately with 2 artery forceps, you can dissect the anterior lamella very nicely and stick it up with glue like you see here. And the glue is very helpful to stick the sclera and the cornea, but you can still take some tacking sutures to tack the graft in place, as well as use the glue to cover with the conjunctiva. And this is the patient 3 days post-op, 2 weeks post-op, a lot of inflammation. He had vasculitis, we needed systemic steroids, 1 month, and finally a year post-op with 6/9 unaided vision. And with that, I would conclude my talk. Thank you for your attention.
Thank you, Daya. Wonderful, wonderful presentation. So, never it became post-IOPS cornea?
Never became, and I always...
Really? Never?
Never. Why? I never try a big bubble in those cases because there's a high incidence of type 2, and we know that it's challenging to deal with type 2. And you can have a very good residual stroma with a manual layer by layer dog. So doing that, the risk of perforation and conversion is almost 0.
What about you?
Same thing. I also just stick to manual dog. I'm not as brave to go as deep as they did in some of those, but once they've had hard drops, we generally go with manual dog. And
Manual dog.
I think with manual dog and a quick contact lens, the patients are quite happy.
Okay. Madam?
So I agree. As he said.
Well, I have to say that I love type 1 big bubbles. I'm scared to death of type 2 big bubbles, and I've had a few in combination. I thought what she did was remarkable, but my experience is that the type 2 bubble does break so easily that I try to avoid. If I see type 2 bubble, I convert to a cut down, and don't try and extend it. I was curious if I was going to ask her, okay, when you have your type 2 bubble, do you just leave it there after you've got your graft in place, or do you pop the type 2 bubble, or do you just let it absorb?
Depends on the size, on the location, but I usually try to avoid to touch it.
You let it absorb on its own.
Okay.
Yeah, I've done that several times, let it absorb, and sometimes I'm very lucky, but sometimes I then have stria in the posterior surface, and it's toward the visual axis or in the visual axis.
Okay. Let's go on with that well. The MEC in Italia. Difficult more and more.
So, thanks very much, Rita. And so, no financial disclosures related to this talk. And as Sophie just explained to us, these are the three main pillars for successful MEC surgery: to control the anterior chamber, to control the vitreous body position, and to control the iris lens diaphragm. So if any of those are not in a proper anatomic status, we are under problems. And as also Sophie mentioned, if we compare what has been published up to now using the MEC versus the SIC for these, especially for these aphakic eyes, the results are in the literature significantly better for the SIC than for the MEC. So this is a relatively recent review, and basically which are the problems with the MEC. There's a significantly increased unfolding time, probably responsible, together with the maneuvers that we regularly use to position it, the trauma to the endothelium, a mean rebubbling rate higher than standard cases, primary graft failure the same, with a significant mean endothelial cell loss, and with less visual acuity, good results than we have with a standard eyes. That's why there has been numerous strategies to deal with the MEC in aphakic eyes, such as secondary implantation of IOLs to establish a diaphragm to compartmentalize the globe, or some others, including one that I learned some years ago, the double bubble technique by Hayashi, which I thought it was a very clever approach for diminishing the time during the surgery. And that's why we start based on this description from our Japanese colleague to describe the single bubble technique, so which basically is to introduce the graft into the anterior chamber, to open it a little bit, to put a small bubble underneath the graft, to grasp the graft, and then to do all the tapping maneuvers that we regularly do, but in this position. And so you can convert the surgery in a relatively short one. So just a couple of examples. This is a high myope vitrectomized eye with a secondary IOL implantation. So as you know, these vitrectomized eyes, especially in myopic group, it is quite difficult to shallow the anterior chamber during the surgery, so it's quite difficult to manage the lenticles. So once the lenticle is inside, I open it a little bit, I just put a small bubble underneath the flap, then I took my forceps, which are a special forceps to grasp with a very large area of manipulation, and then I used the standard tapping maneuvers over this small bubble, and once it's open and it's convex, then I centered, because it's not attached to the stroma, and then I introduce the gas. And also, in aphakic eyes, I do basically the same. In this case, we will obviously restore a little bit the pupil after the standard maneuvers. As it was mentioned, if you have air in the anterior chamber, and I like to have this constant infusion of air during the procedure, the visualization gets better and better. So because you dry the posterior surface of the cornea, in this case we closed the pupil, in this aphakic case, and we'll do the same. So we will introduce the lenticle inside the chamber. Well, each one of us has its own way to do it, but anyway, we open a little bit the flap, I put a small bubble underneath, then I grasp the graft, and then not too much. It's important to control this, because if you put too much, then you position over this small bubble the graft, your forceps, you center it, and then you increase the bubble. Finally, just to show you that in some cases, in aphakic eyes, where I have the doubt that the pupil will allow me to leave the proper gas bubble, I use an ICL, and just for a question of time, because I have 6 minutes, this is a standard, this is a vitrectomized eye, so I will use also the bubble technique. But as you have seen, excuse me, here, before I do all this stuff, excuse me, I forgot to show you that I introduced an ICL over the iris surface in a convex position, in an horizontal position, because I like to have my inferior iliectomy free. So then this allows to have the gas inside the anterior chamber with the following 4 or 5 days, and after 1 or 2 weeks, what I do when everything is set up and my cornea is clear back again, then I will, under viscoelastic, I will remove the ICL from the eye, which is a relatively easy procedure. So in summary, there are obviously certain limitations, as it has been mentioned, performing the MEC in aphakic and vitrectomized eyes, and I absolutely agree that if your technique of choice is the side, it's fantastic, as long as you do whatever you think it works better for you. But if you do the MEC, I think that this kind of technique will allow you to do the surgery quicker and so safer. And that's it. Thanks very much for your attention.
So, frankly speaking, any more space for the S.I.C.S.S.O in these cases?
Yes, but I also sometimes try the DMEC for these cases, but the name of the game is, as Jose said, to hold the graph so it doesn't go down. So we have published a case series of these graphs going down. Actually, it was from some years ago when I had one D-set disappear, and I didn't know where it was until it was found in the vitreous. And then I went around the country, I asked, does anybody else have any cases? And a few brave souls gave me some cases. So we have published a case series of those. Of 8 of those cases, only 2 were a fake kick. The rest, the 6 had like some sort of IOL, either sutured IOL or open capsule or something. Anyhow, so the case, the most important thing is what you said, hold them. But if the macula doesn't have the potential, then like what Sophie said, then D-SEC is great for those cases too.
Yes, Mark?
So, as usual, Jose was very innovative and an amazing surgeon. Those were great videos. One other alternative I want to mention for doing aphakic DMEC is with the endothelium in technique, a pull-through technique. You can take the DMEC scroll and you can fold it over very little helon, and so you put the endothelium on the inside, and then you load it up into injector. You go just like a boost and glide, but for DMEC, and you then pull the tissue cross chamber, and it will open up on its own because its natural tendency is to open that way. It sounds easy, but it has its challenges like any other technique. But it does allow you to hold onto the graft, make sure that it's secure, and when you pull it through, then your operation is almost over. So I think that's a technique that is worth looking into because it does provide us an alternative to tapping our grafts open.
And so, rest in peace, D-SEC.
I mean, I really wonder, like you said, what's the status of the eye? A lot of these eyes that have endothelial failure, I find, unless they have previous Fuchs, they usually have a tube that was maybe in the AC and then moved to pars plana, so they got a trabeculotomy. What am I gaining by doing a DMEC? And at the beginning, we did too, and like I used a similar kind of folding technique. I think we, in our group, kind of came to the conclusion that maybe it's not worth it. And so thin D-SEC, ultra thin D-SEC seems to work quite well in these, and that's what we've transitioned back to.
I completely agree. The potential vision of those eyes usually are not as good as one eye for DMEC, so I go to a D-SEC.
One tip is, you know how for DMEC we want the chamber to be shallow, and these post-vitrectomy eyes, it's really hard to get shallow. So opening the lid speculum, simple things, really shallows the chamber. Sometimes pressing on the side of the eye, because these are vitrectomized eyes, so it shallows the chamber. And then sometimes going with the cannula and really sucking the fluid out.
Speaking about vitrectomized eyes, Vincenzo Morino, DMEC in vitrectomized eyes.
Thank you very much, Rita. Thank you very much, S.I.C.S.S.O, for inviting me here. As we know, it's a controversial issue because there are different ways that you can skin a cat, and D-SEC works well. These are the normal difficulty when you start DMEC, and you must think that with vitrectomized eye, these steps become even more difficult, even for accomplished surgeons like Jose and the people here. So why DMEC is more challenging in vitrectomized eye? Because there is loss of posterior vitreous. That's the same reason why DMEC is actually easier in phakic eyes, because you got the lens as well, and it's really easy to open the graft unless you cut a very large graft. And because of that, there is a higher risk of intraoperative and post-operative complications. So, but let's not forget that any surgery is difficult in those eyes. D-SEC is difficult, and if you look at this case series, although the outcome appeared to be better in D-SEC, all the DMEC had pars plana infusion, and the major complication was retinal detachment CME, and one may wonder if that was the reason why there was more of this complication in the DMEC group rather than the D-SEC group. This is the same paper from Romano that Jose showed before. that shows really that these are complex cases and DMEC can work in those cases as well. And this is what we looked at our own cases, and in a period of a few years, 14 eyes of 13 patients, and the complications were higher, and some patients had to undergo repeated surgery. However, this was in 2018, and now things are moving on. And for instance, Jose mentioned about the bubble technique, which is very useful. An extra lens in the eye to create a compartmentalization between the anterior and the posterior chamber, and the net technique for aphakic eyes proposed by my colleague Alfonso Vasquez Perez. What I like to do is use a simple flaring ring, because that reduced, at least in my experience, extensively the collapsibility of the eye. This is a patient with an only eye. Let me stop there for a second. So he has got a glaucoma drainage device. I sutured the SICSSO at the time of the previous DMEC 4 years earlier, because putting a suture lens in this eye was too complex, and he had a full pars plana vitrectomy, and this is only good eye. So in this case, I have the personal proof that when I did it last time was really difficult, but this time with the flaring ring, everything looks a lot easier, and was even relatively easy to flip the graft upside down, despite the SICSSO was sutured, so it was not moving and ballooning, and then I could use just relatively standard tapping maneuver to open the graft, and making sure, you can see from the arrow mark, that the graft was in place. And in a few cases, these are the ones with the longest follow-up, and intraoperative, I know it's a personal subjective judgment, but the anterior chamber and eye collapsibility was judged by the surgeon to be really very, very good. And from the anterior cell count, you can see that maneuvering was short, because one issue with these eyes that they spend endless time, exactly to when you start trying to unfold, open, and stick the graft down. So, in vitrectomized eye, I think it's also important taking into account the donor factor. Sizing is key, because sometimes these eyes are large and you don't want a small graft that rolls. Marking the graft is important, and as everyone knows, I'm a great believer in the arrow mark, because I get always mixed up when I see the S. Is it the correct way? Yes or no? Bubbling, I hardly use SF6, but in these eyes, I prefer to use 20% SF6. And the other thing that helps is, rather than pars plana infusion, because I'm not a vitreoretinal surgeon, I did my last vitrectomy over 20 years ago, just inject on BSS, especially at the time of the bubbling, so you create a differential pressure between the posterior and the anterior chamber. Another hidden advantage of DMEC is that you can rebubble in the office, because DMEC doesn't dislocate, or at least not always, unlike a DSEC, where once the graft comes off, you have to take the patient back to theater because the graft is floating in the anterior chamber if you have one. So this is just a reminder of the Moorfield's clockwise arrow mark, and in this short video, I'll try to be even shorter than 6 minutes to help you can see that this patient has got both marks, the arrow and the S mark, which I did myself, and that's after a PKP. You can see immediately the arrow mark, but where is the S mark? I have to go on high magnification, pump it up with there, and then I am still confused. Is it the correct orientation or not? Perhaps I'm dyslexic, I'm not sure. And that's how we do the rebubbling in the clinic. So this is a patient not vitrectomized. This patient, you can see that on the OCT that the DMEC is not fully attached, massive corneal edema, anesthesia, povidone iodine, and then we make a little paracentesis with what we call a pediatric MVR knife, because it is the sharpest MVR blade that you can get, and then you inject a full bubble. The patient stays with us in the clinic lying flat in a little room for half an hour. We check the pressure, off he goes, and most of the time this works really beautifully. Whilst with a DSEC, you will have to take this patient back to theater, I think 99%. So just my tips and tricks for vitrectomized eye: always use a mark that you're very happy with. Flaring ring has helped me and my colleagues to avoid or minimize eye collapsibility. Intravitreal BSS injection, especially bubbling time, to create a pressure gradient. And remember that it's easy to rebubble these cases with a cooperative patient in the office. Thank you.
So let's give a new life to the flaring ring.
That is innovative. I think that it helps to stabilize the anterior segment. One other thing that we do is as we were taught before to put pressure on the sclera. You can either have your assistant do it, you can tighten the lid speculum. We've also taken a piece of Wexel sponge, placed it under the lid, and that enables to have posterior pressure, and we don't need the assistant for that. I think that we can't stop doing the S.I.C.S.S.O because some people will have much greater success with the S.I.C.S.S.O. We can have innovation on using DMEC on these eyes. So it comes down to still to a choice of the surgeon. You have to do what you feel most comfortable with. And with ultra-thin S.I.C.S.S.O now, the visual acuity, it gets very close to what a DMEC is, especially in these compromised maculas.
So I haven't tried the Floringo ring. Vincenzo, I'll try. It makes sense. It really shallows.
Yeah, same. I'm gonna try that at home. Do you tighten it a lot, or is it just like normally like you do for PK?
Great, very useful.
And what about the rebubbling? Always at the slit lamp.
Well, I was interested about the rebubbling I saw there because we don't need a needle. We already have a paracentesis site inferiorly, and when you rebubble, it's very easy to open with a Sinski hook or a spatula at the slit lamp in the clinic. The other thing is we've separated the syringe from the cannula because it's very technically difficult to hold your hand still and push the syringe and not have the cannula moving about. So we attach the cannula to a line, a line like an IV line, and to the syringe, so that one hand holds the syringe while you're at the slit lamp, and the other hand is perfectly still. And we have a video on that. It was Chris Salas, one of my fellows, that came up with this idea, and it's changed everything. It's so easy.
So for both DMEC and D-sec rebubbling, I do it like the slit lamp, unless D-sec is way in angle. And I do go with a 30 gauge new site rather than the paracentesis. And if I need to recenter it for D-sec, since it could be sort of decentered off, I use the LASIK roller, the Lindstrom roller, and roll it up. It's a little uncomfortable for the patient, but it works if it's not quite in the angle.
So for DMEC, we use a 30 gauge cannula in our paracentesis.
Perform a new incision or use it there?
No, do a little paracentesis. I really want, like, we try to use one that's kind of where the graft is attached. And especially for achieving a high pressure, we try to use the incision as a valve almost. You know, you're kind of injecting, you're not all the way in, you're kind of injecting halfway through for the air to go in.
Because sometimes it's not so easy to know which is the right amount of air.
Well, I think it's very simple. You open up the paracentesis site, you put the cannula in, then you push down on the cannula and open up the paracentesis. The fluid flows out, and then you just push air in, and it's almost impossible to completely fill the chamber, but you get a beautiful big bubble. So I don't like the needle approach because I've seen patients come in with pressures of 60 and 70 because they got rebubbled without releasing any fluid. So that's my strong feeling.
Removing some fluid could be very, very useful in these cases, in my opinion.
Actually, the anterior chamber, when I put the 30 gauge, never gets filled, as you said. So then I check the pressure right away, and then I have the patient dry for a few minutes, and the pressure does come down. In fact, I usually want the pressure higher than what I get because I can't fill it fully.
Yes.
The same, but I think the most important thing is, as Mark said, to have a line, directed with the syringe. The ergonomy is much easier doing that.
With the yes. Yes, I know, I saw it. Okay. And what about you, Jose? Do you perform every refilling rebubble like the slit lamp, or?
I completely agree with Mark that when I do a rebubbling, which is extremely rare. But anyway, when I need to do that, I always want to release some accuracy. And no, I am never doing it like that. We have a small office at my institution, so I don't need to go to the operating room, but I want to have my patient lying down, and I want to be under the microscope, and I want to do, well, that's...
Okay, thank you, because I know that there are different opinions about this. And what about you, Caterina or Enrica? Rebubbling, slit lamp, or in the OR?
I like to do it in the OR, but it makes sense to do it as slit lamp as well. I like to do it in the OR because I have a private practice. I just go upstairs, I have my patient lying down, especially if it's I have to do with rebubbling, that it's a couple of days after surgery, and I don't see very well the tissue. To me, it's very easy, and I always like to do an OCT to make sure that I enter from the right side, because with my first DMAC, I can say that, I put the bubble between the donor and the recipient, and you don't want to do that. I mean, you can still fix it, but you know, it's better to avoid it. But it makes sense to do it in slit lamp. Yeah, that bubble.
And how long after the slit lamp rubbing you keep the patient lying?
We check the pressure about 1 hour afterwards. I also make sure that the peripheral iridectomy is uncovered. We don't have the patient lie down, we just send them home. What you find with not only DELECT, S.I.C.S.S.O, and DEMEC is that once the tissue has been inside the body for several days, it's had food, it's had warmth, it's come alive. And so the bubble is not as important. It doesn't need that much time. And that tissue will attach like glue because the tissue is very happy to be in that new body as opposed to right after surgery.
So, we have Dr. Pereira from Brazil. My most difficult DMAC case. I can't imagine what else.
Hello everyone. I want to thank the invitation. It's always a great pleasure to be here at S.I.C.S.S.O. And I'm going to present one of my most difficult DMAC cases. It was not easy to find this case, and I'm going to say that it wasn't the most difficult DMAC surgery, but probably the most difficult DMAC case. And I don't have any financial interest to disclose. So the case was a 36-year-old male that has low visual acuity in both eyes. The left eye was bad visual acuity since birth, and his right eye was the good eye, but worsened 2 years before he came to our clinic. He had cataract surgery, a complicated cataract surgery in his right eye with posterior capsular rupture and anterior vitrectomy 1 year before. And he was implanted a hydrophobic IOL, and that's important because we always try to find and to know which IOL was implanted in every pseudophakic patient that we perform endothelial keratoplasty, because we have a technique for hydrophilic patients that we can avoid, or at least try to avoid, opacity of those IOLs. And 6 months after cataract surgery, this patient needed a trabeculectomy for high uncontrolled IOP. And he was 2400 in his right eye, the best corrected visual acuity. The left eye has a weak hand movement and nystagmus. The IOP in his right eye was 9, and in the left eye was not possible to measure. He had important corneal edema, anterior synechia 360 with correctopia, and a topical IOL. The corneal diameter of his right eye was 9 by 8 millimeters in the vertical diameter. And the left eye has microphthalmia with a completely opaque cornea. In the ultrasound, it was normal in the right eye, but has an axial diameter of 17 millimeters. And he was referred with a history of best corrected visual acuity of 2100 before having cataract. And he had a history of subtotal nerve cupping after the trabeculectomy, but before having the bullous keratopathy, so they could see that he had a very, very advanced glaucoma. You can see the image of the right eye here superiorly. He had a very shallow anterior chamber with synechia, and in the left eye we can see a completely opaque cornea. So we had a single eye with important corneal edema, microphthalmos, shallow anterior chamber, pseudophakic that was underwent with anterior vitrectomy, and it was performed by an experienced cataract surgery. This cataract surgery, it's important to say that. He underwent trabeculectomy, he had advanced glaucoma, anterior synechiae and correctopia, and he was very, very afraid of undergoing surgery. In his cataract surgery, the surgeon talked to me and he talked to the patient that he had a very positive pressure during surgery that was difficult to control, and that all those complications happened because of that. And he was even happy the way that finished the surgery because the positive pressure was really bad. So what we'll do, penetrating keratoplasty, a DSEC or a DMEC? Well, you know the title of my presentation, so it's obviously I perform a DMEC. And what made me more comfortable to decide was mainly because of the very shallow anterior chamber and a very small eye, a microphthalmic eye that has positive pressure in the previous surgery. So I wanted the smallest incision possible in this procedure. So here is the procedure. And you can see that the eye is really small. Look at the cornea. All the instruments, they look really big in the small eye. So, and if you see the paracentesis, you could see some aqueous going out of the paracentesis. So we started endovenous medication to lower the IOP, because you can see that the viscoelastic was going out. So the pressure was not so positive, but we had some positive pressure. So we performed the synechialysis, and now we're performing the pupilloplasty, because we need to have a well-formed diaphragm to avoid the bubble going posteriorly. Look at the intraocular seizures, how big they look. So it was really a small eye. Now we're closing the superior part of the iris defect. And then we're just closing the sutures of this pupilloplasty and cutting the remaining suture. We performed an inferior iridectomy. The stripping was really peripheric because he had edema for all over the cornea, and we had an 8 millimeters cornea. So the smallest trifine we had was 6 millimeters, so it would be a big graft. Look at it was a 2.2 incision. Look how big it looks. Now we're taking the recipient SMA, taking all the cohesive viscoelastic use. So look at the graft. It's a 6 millimeter corneal graft. So the DMEC graft looks really big. Now the pressure wasn't so positive as it was in the beginning because of the endovenous medication, but we could check the correct orientation by the Matsuri sign, and after that we were unfolding. And in the end we had some difficulty to unfold this part, but it was probably because of some fibrin, but we could finish the surgery well. So that's the surgery, and as I said, I think it's not the most difficult DMEC procedure that I performed, but the whole case was really difficult to manage the patient, the families. He was a young patient that needed to provide a family, only eyes, so it was a really difficult case. 7 postoperatively, he was hand movements because we used gas, because we didn't want to over-pressurize the anterior chamber because of the total cup disc. And the IOP was 8, 1 week postoperatively, and with 2 weeks postoperatively and 1 year postoperatively, he was 2100, and that was the best vision he had ever had, and with a good IOP controlled. So that's the bad case. I want to invite everyone to our city, to Sorocaba, to our hospital, to our congress in the end of October. I want once again, thanks for the invitation, and thank you all for the great day. Thank you.
Wonderful case. Congratulations. What to add?
Well, first of all, that was superb surgery, and your hands look very steady, even though it was a very difficult case. The question I would have about this case is what happened post-op with the peripheral anterior synechia with the iridocorneal adhesions. We know in ice and other conditions they always come back, but did you get lucky and not have these come back?
There was a tiny synechia just beside the inferior iridectomy. The rest didn't come up.
The rest stayed away?
Yes.
That was very fortunate.
Yes.
And the pressure, by the way, what did you do with the pressure after the surgery, immediately after surgery? Were you worried about having too much pressure for the air bubble?
Yeah, so I used gas to avoid big pressure with the air bubble. That's why we always try to know what kind of lens the patient has, because if he had a hydrophilic lens, then it would be a lot harder. Because I wouldn't be able to pressurize, but I wouldn't be able to use gas. I would need to take some air in the end of the surgery, so the air doesn't have contact with the IOL. But fortunately, the IOL was hydrophobic, and we could do it without rising the IOP and damaging his optic nerve.
Natalie, any suggestion to prevent synechial recurrence?
No, as you did, cutting it, and then during the surgery, I tried to make sure that there is good distance between the cornea, the air bubble between the cornea and the iris, and the air bubble covers everything. And of course, these cases, I'm sure you have a little more steroids on board afterwards too.
Maybe yes.
The only thing I would add is this is, I think, a good place to use an oxyparin.
Yes.
Because we use it for our uveitic DMEX, and they turn out beautiful, like way better than you think they'll turn out.
We didn't have an oxyparin at that time. We didn't know it. It's an old video. But today, I would definitely use it.
I'm privileged to live in the same country as Nicholas. I would refer to him in this case.
Okay, let's move on. Caterina Sernicola, thank you. DOLC inactive infectious keratitis.
Good evening, everyone. I'm gonna present this case of a female young patient. She was doing orthokeratology for several years, and she had an HSU stromal keratitis 1 year before, and she was no longer on a prophylactic therapy. So she has some unsettled symptoms in the end of May 2024. Her primary doctor suspected neuropathic recurrence, so they put her on systemic acyclovir and topical ganciclovir, and they switched her to systemic valacyclovir after a worsening of symptoms. After 2 weeks she was worsening, she saw another doctor, and they referred to us for suspected acanthamoeba keratitis. I saw her on June 13, 14 days after symptoms, and she has this corneal edema, a lot of inflammation, some hypopyon, and this ulcer, the depth is about 240 microns, and the visual acuity was count finger. So we did PCR for herpes and acanthamoeba, and we add propamidine and PHMB on therapy. And the problem of this patient is that she's not just asking to save her eye, but also to save her participation to the Olympic game, because she is a pentathlon athlete, so she's a very good one. So she had 40 days before Olympic game. So we start the treatment right away, and the PCR came back positive for acanthamoeba. She had good response to medical therapy, because 6 days after she has less edema, no more hypopyon, improved visual acuity, but she has some bigger epi defect and increased pain, so she wasn't able to practice. So since she was having good response to therapy, we had lotepretrol twice a day and bandage contact lens to help to manage the inflammation and the pain. So 45 days after treatment, she has less inflammation, less photophobia, better pain control, but she started having neurotrophic aspect and some stromal thinning. Anyway, since Alice is a really great woman, she was able to participate to the Olympic Games. So after all the challenge about the Olympic Games, 3 months follow-up in September, she came back to us because her vision was worsening. She has 2200. She has this central opacity and persisting epi defect and some stromal thinning, because the original pachymetry was about 600 microns. And she was complain about as poor quality of life, because it's 3 months that she's struggling with this eye and she cannot compete in high level anymore. So what can we do next for her? So as you all know, we are doing several cases of dark and active infection, but in this patient, she was responding well to therapy. The infection was well controlled with the medical therapy, but she really wants a quick fix of her problem and coming back to her normal life. And she has also this big epi defect that was a problem when she was practicing swimming and fencing and equation. So we decided to move to a therapeutic talc. In this case, the surgery is important at the beginning. We do a very large and deep debulking because we want to remove the focus of the infection at this stage of the surgery. And to be sure that we've done that, we have to prepare peripheral and deep margin for the pathologist. We prepare the peripheral margin using a smaller punch, so we have this peripheral ring that we send for analysis. And then we change gloves, drapes, instruments. We do a betadine and propamidine wash. And then we prepare the deepest margin for the pathologist. To do that, we use the peeling off technique. So we use this blunt spatula, the same that we use for cannula bubble. And we create a 360-degree track all over the trephination group. So we try to go deeper and deeper, and when we feel less resistance, that means that maybe we are deep enough, and we open this track, and we proceed in a spiral fashion, so maybe 1, 2, 3 rounds, it depends, until we are deep enough, and we can just peel off the stroma using 2 forceps. And this amazing technique was described by Malbrand in 1966. So at this point, we have a deep margin that we can send the pathologist to be analyzed as well. So the results were both peripheral and deep margin were free of infection, and this is good because we can discontinue acanthomeba medication that is toxic for the surface. And this is the 7-month post-op, no recurrence. You see the beautiful residual bed and also low astigmatism, so she's back to her normal life. And I can tell you that to manage this kind of patient, we really need a team effort because we need a good microbiologist, good pathologist, and also local ophthalmologist because she lives far away from us. So I have to thank all these people. And again, we invite you all to Cagliari next year.
Wonderful. We discussed also this morning about this interesting and promising procedure. What I want to know is how do you manage the steroid eye drops after the surgery? In this case, the rim was negative, but it is always negative.
Not always. Sometimes it's also inconclusive, so they cannot tell us. So we keep patients on steroids, but we keep with also anti-acanthomeba medication for several months.
Several months?
Yes.
Okay, in case of doubt.
Yes.
Okay. Thank you, Caterina. Thank you so much. So, let's move to the last but not least one, of course. Vasquez Perez. Management of complication in osteodonto keratoprosthesis. An Italian touch.
Thank you very much, and good afternoon, everyone. So we're just getting out of corneal transplants. Actually, thank you very much for the invitation. It's great to be in Italy, actually, where the osteodontic keratoprosthesis started in the 60s and 70s with the Stramfelli and Falcinelli. For those of you who are unfamiliar, what is this technique actually? This is what we treat with osteodontic keratoprosthesis. These are blind patients. Perception of light bilaterally because of the most severe conditions of corneal blindness, as you can see over there in the list. So the technique basically is a capro, it's a keratoprosthesis, it's a biological capro. It uses osteodental tissue just to host the cylinder, and it's just inserted onto the eye. I'll just show you a bit briefly what it is. It's the most enduring type of capro. This capro lasts decades, right? But obviously it's a complex procedure. Even though you are an accomplished surgeon, you need training for this, and you need time, and you need a multidisciplinary team, right? And that's why it's only available in a few places in the world. So a few years ago, the osteodontic keratoprosthesis was moved to Moorfields, and that was our first new patient, actually. As you can see, it works really well in restoring sight, and you can have full sight back on these patients, right? So how we do it is basically we need to do it in 2 stages. In the first stage, we work with a maxillofacial surgeon, taking the tooth and bone, fashioning into a lamina with a hole in the center where we insert a cylinder. At the same time, we cover the eye with buccal mucosa and we insert this initial device under the skin for 3 months. So 3 months later, we come back, we retrieve the device, go back, check that it's in good conditions, go back to the eye, so dissect the buccal mucosa, and then just open the eye, remove the iris, lens, anterior vitreous, and then just we insert the lamina, and patients can recover vision. However, for those who do capro, there's always complications in these patients. One of these is obviously glaucoma. And it's sad to see a patient that recovers the full vision and goes slowly to blindness. And the problem is we cannot use drops here. What we can do is only surgery, and we can usually do, or been doing, is implanting tubes. The problem is that the tubes were only temporary in these cases, and we knew why actually. Until the surgery was moved to Moorfields, we were unable to do more for these patients. But now we have a multidisciplinary team, and this is endoscopic vitrectomy. Right? I have a colleague, Mr. Rob Henderson, who does endoscopic vitrectomy in Moorfields. So now we can go inside of the eyes, because through this small opening, which is the optical cylinder of 3.5 millimeters, you cannot see the periphery of the retina. And we are able to confirm that this is the tube and this is the vitreous. So the vitreous is blocking the drainage of the tube. So now we are able to go back to unblock the tubes, and just not necessary to implant a new tube, and the patients can preserve the vision. What happens if there is retinal detachment? So as I told you, the challenge is not only doing orthodontic prosthesis, providing surgery, which is already complex. The challenge is to treat the complications. And that's what I think it makes a bit of the difference. So retinal detachment is the same, right? You cannot just do a pars plana vitrectomy in these patients. You need an endoscopic approach. And that's, we are lucky and privileged at Moorfields Eye Hospital. And we can use that, and patients can regain vision, can recover vision, can preserve some vision. But obviously you see, the endoscope gives us a really good visualization of the periphery of the retina, which you cannot have with a conventional pars plana vitrectomy. One thing that's in all the cases that you have is the patient can lose vision because of a membrane in the posterior part of the optical cylinder. And this is annoying because the patients have enjoyed a fantastic vision. They have intraocular inflammation, retinal detachment, which is sterile vitritis, and they lost the vision because of the membrane blocking the eye. So now we've just been working with the retinal colleagues and the team, so now we just use a kind of a different approach. In the past, we used sometimes to open the eye, buccal mucosa, remove the lamina to remove the membrane, and did not always work, and this was taking a lot of risks. So what we do nowadays is just try still the approach, the minimal invasive, just using an endoscope just to visualize the posterior part of the optical cylinder. That's the optic nerve, and this patient had a previous retinal detachment. You can see that's the membrane. And now what we can do is just basically guided by the microscope, just go with a needle and just cut that membrane, and then just hold it and just remove the membrane from the other side with the hand. And then the patient recovers the vision, and it's really great. So sometimes it's even more complex. So unfortunately, the bone and dentin, this resorbs over time, so it's not going to last forever, and that's the problem. These laminas become loose or become small, and the eye can leak. And this is one of the patients that come in the previous place that I was hosting the service in Brighton more than 10 years ago, actually, with a perfect vision in an only eye with a very rare syndrome, and just came to the A&E with a leaking hypotony and visual decreasing, the vision decreasing. So unfortunately, sometimes you need to go back. It's just this last video to show you how difficult it is, this patient. So once you change the anatomy of the ocular surface, everything becomes more difficult. The buccal mucosa bleeds a lot, actually, and it's not difficult to perforate the eye if you are not careful. So you need to be patient, and this procedure usually takes hours until you get the plane of the sclera and where you can safely do your dissection to get over the lamina, basically, and then you can observe. This lamina is very small now, it's very thin and thin, but this patient has no other tooth just to do another lamina, so that's the leak. So usually there's small breaks, small fractures in the lamina and the bone, and the patient can leak. So one of the things you can do, or we usually do, is reattach, or try to reattach the lamina to tighten a bit that junction, and also use a special material that's probably a dental, you know, we usually work with maxillofacial surgeons and dental specialists who provide us this kind of material. Say, well, you can use that in the junction or where you see the leak, just to seal that that leaking. And that's what we usually do. I would just see is that basically once we do the resuturing of the lamina, we just fix the lamina. So we apply this solution. There is a solution where the leak was basically happening, and that usually is very, very successful and stops the leak. And the patient still, after 2 years, have treated that complication, still doing well and preserving the vision in his only eye. It's a very young patient. So just to finish, this is obviously a highly specialized service. Morpheus now hosts the OKP for the United Kingdom, and we also receive patients from all over Europe. And thank you very much again for your invitation. Yes. So. Yes. Well, what I will say is, at the beginning of my training, you know, I did a fellowship at Brighton actually with Christopher Liu, who was trained by Falcinelli before, and I was just fascinated with how the patient goes from blindness to full visual recovery. But it's not only the surgically training that you need; it's also the experience, and that takes time. Yes. Right? So decisions that you make. And in every surgery, you need to take risks. You know, you need to be familiar with it, because sometimes during surgery is like a game over if you made a mistake. If you have a choroidal bleeding, for instance, you know, when you do stage 2. So, what is important is to have a multidisciplinary team. And if you have a glaucoma surgeon, you have a vitreoretinal surgeon, obviously you have your maxillofacial surgeon, your anesthetist, you feel more safe, I would say, for patients, and you can do it. And we are lucky at Morpheus, Vincenzo, we are quite a few of us also. I have colleagues who are more experienced, and always you can have an advice. It's demanding, but it's very rewarding.
Yes, I think so. Compliments, really terrific surgery. So, it's finished. I thank really every speakers, very, very wonderful presentation, a wonderful panel, and so I really hope that you enjoyed this session about the complex cases. Thank you for the attention. Yes.
Bueno, I need a favor that I can favor. Dove è possibile? Non era male, non era male. Vedo sono pronti dalla
Che ci sia un motivo.
dato una marea sì, in realtà non bisogno.
Fortunato dei materiali che hai preso, no?
Che gli ho dato tutto.
Che gli hai dato tutto. Ma non ti sei tenuto una copia niente?
Ma tutto, certo.
Di tutto. Se lui non ci fa niente, no?
Te lo ridò.
Lo farai te? No?
Bravo, infatti io quello che volevo dire, solo che devo chiedere a lui perché ancora
non... Aspettiamo, se lui non ci fa niente...
lo monto io e ci divertiamo.
Sì,
facciamo... Sì, ci siamo capiti.
Sì. Vado a tenere.
Good afternoon. We'd like to get this final session started. There's a very important social dinner tonight that we all want to make. We're very, very excited about that. So this is an update on ocular surface disease. But first of all, we're starting with live surgery. And I believe Dr. Greenstein, is he connected here?
Yes, hello.
Hi, so we're going to see a CTAC procedure, which is corneal tissue addition keratoplasty. Steve, can you hear me?
Yes, I can. Can you hear me?
Yes, sounds good. Why don't you talk us through what you're doing, okay?
Sounds good. So hello from Teaneck, New Jersey. This is going to be the CTAC procedure, the corneal tissue addition for keratoconus. Look right at the green flashing light for me. Find the green flashing light. Perfect. So I previously marked the axis of the incision and the distal axis that the inlay is going to reach at the slit lamp just before the patient became supine. And next, we're going to actually mark the cornea based off of the surgical plan that I have from CorneaGen, 2.5. 2.5. Yep. So we have these marking set, which goes in 250 micron steps. So the first mark is supposed to be at about 2.4, so this is 2.5. So we go from the center of the pupil to the inferior axis, and we'll go just slightly inside that when we make our mark. 2.25. Temporally, we're going to mark 2.25 now. Excellent. Good. Working. Then we encompass those marks. In this case, we're using a 4.5 millimeter diameter. So we have optical zone markers that range from about 3 to 5 millimeters. In this case, it's going to be 4.5. And you want to make a pretty dense mark here because you're going to have to see it on the femto laser when you're making and finding where you're going to create the channel. So that looks excellent. Bring your chin up a little bit. Good. Going to give you a little more numbing here now. Can you give me actually 2.25 again? That's fine. Either one is, that's okay. Yeah, that's fine. Going to place one more mark right around the incision axis. This allows me to account for some cyclotorsion along the way. Good. A little more numbing here. Look straight at the green light. Good. Good. Then in this case, we're using the Z8 laser, which we're going to use a 10 millimeter ring here. Bring your chin up. So it is a wide ring. And apply suction. Your vision is going to go dim and dark here. That's all going to be normal. Good. You're going to feel a little pressure here now. Perfect. Adjust the light to the right, to the right, to the left one. Rotate to the left. Yep. To the left again. One more. Good. And to the left, to the right one. And down one. And start resection. Excellent. All right, so just going to be 30 seconds here. Don't talk or move. Everything looks perfect, perfect, perfect. You're doing great. You're doing great. Hold it right where you are. That is perfect, perfect, perfect. You're doing great. You're doing great. You're already halfway done. Perfect, perfect, perfect. Just hold it right where you are. You're doing great. You're doing great. You're coming down the home stretch now. Just keep it right where you are. That's perfect, perfect, perfect. Last few seconds here, almost done, and that is it. Excellent. Look right at the green light. So you can see with the dense mark, we're able to then get a good approximation of where the channel needs to be. And that looks perfect right where it is. Excellent. All right, I'm going to give you a break here for a second. Just close your eye. So I'm going to get the inlay just prepared. It's going to just take a minute. It comes in a vial of albumin here.
Say, Steve?
Yeah.
Can you tell us what information you gave CorneaGen and what they did to prepare the tissue?
Absolutely. So with the Pentacam, we upload the topography using the CTAC uploading software. And once you upload the topography, actually, CorneaGen is then able to take that topography and provide you with a recommended plan. Once you have that plan, it essentially has 4 parameters to it. It has a inner diameter, an outer diameter, a thickness, and an arc length. And you can adjust any of those if you want. For the most part, at the beginning, most people use the recommended parameters. But as you get more depth with it, you might find you want to increase thickness for a little more flattening, or widen the inner diameter if you want to get a little more area around the pupil. At the end, the surgeon then confirms the plan that they want, and then CorneaGen will cut the tissue on a femto laser in their facility, and they send it in a box in a vial of albumin with a strainer that's able to hold the inlay in place. The inlay itself is actually shelf stable for 2 years. So you're able to kind of store it and plan your surgeries accordingly. So the inlay is ready. So now we're going to get ready to place the inlay. Excellent. Okay, so we're going to cover around your eye, keep everything around it all clean here. Excellent. Going to give you a little more numbing here now. Might sting just a little bit there. Close your eye. Going to cover your eyelashes here, so look down for me. And look up for me. So in this case, the recommended parameters was a 300 micron thickness, a 230 degree inlay with a 4.5 millimeter inner diameter and an 8 millimeter outer diameter, recommending the incision to be at 62 degrees with the inlay from 47 degrees to 177.
And that was based specifically on the Pentacam from this patient, right? So a custom inlay.
Correct. Excellent. So a little more preparicane, a little more numbing here now. So the key really with being able to place these inlays is full dissection of the channel. So unlike synthetic ring segments, lift your chin a little bit. Unlike synthetic ring segments, you really need to have a good dissection to be able to get the inlay into position. Once you do, it will actually guide through the channel fairly smoothly. So we just make sure that we break any of these small adhesions along the way. The Z8 has 2 incisions. The second incision here is a little more vertical, so I just use a S.I.C.S.S.O to kind of get into it. LASIK dissector. These channels are only 200 microns deep, so unlike also synthetic inlays that you place at a much deeper depth, in this case, you're really working in a much more shallow, more like working in a LASIK flat depth. So the opening, the incisions, is a little more straightforward. To the right. Okay, so for anyone who's done manual dissection of intacts in the past, or any of the ring segments available. You know about kind of opening the channels with these dissectors here. Again, the key is just making sure that you kind of go back and forth. You have a good view through the ring to be able to ensure that you're kind of seeing everything happening, but you really just want to make sure that you have good dissection all the way through. So I really am pretty aggressive on the dissection just to make sure that we don't have any adhesions along the way. To the left. You drop S.I.C.S.S. for the cornea. Try to find the green light for me. So again, going in each direction, just to make sure. Excellent. There was one adhesion there. Good. We seem to be in pretty good dissection there, so I'm going to take the inlay. So the inlay's pretty easy to tell kind of its orientation. It follows the curvature of the cornea, so you can tell what's up and from down. Yeah, you can place a little into that. Good. And I like to just sort of get a sense of where it's going to sit, find the green light for me. And then it is important to dry the inlay, so you really do want to have a dry surface to kind of work with when you do place it, something to grip. Excellent. Straight to it. And I like to hold it pretty close to the edge, but not all the way, just to give it a little area to be able to go in. Now, you don't have to dehydrate these inlays, so that's very helpful. They have a structure to them already from the gamma radiation process. Good. Excellent. Look down a little bit. And then I try to support it just as it goes in there, and I look right back at the green light, just to keep it in the channel there. And then these C-TAC forceps are designed to guide the inlay along the channel as you kind of try to bring it into position. 0.12. Look straight at the green light. You may feel a little pressure here. But you can see it really nicely guides along the channel pretty much the whole way through. Manipulator. Then we can come in from the other direction. I probably could have even pushed it all the way, but we can come in from the other direction and just kind of guide the inlay the rest of the way through. Bring it all the way there. S.I.C.S.S. on the cornea. Look right at the green light. I'm going to bring it a little more around here.
Steve, as this tissue's going in, what are some of the things you're worried about happening?
So I mean, I do try to be careful around the incisions. You know, you are working in a 360-degree sort of channel as you're manipulating the instruments to bring it in both ways. So I do, be careful around find the green light for me. I do try to be careful around the edge of the incisions, not to tear them in either direction. There is sometimes that you can get a little tear on the side of the channel, which the inlay does not move, so you can still place the inlay into position and it works very well. One of the nice things about these inlays is once they're in, and once the endothelium starts, pumping, these inlays really don't move. I'll manipulate it a little bit. They really stay in position. Even when they're close to the edge of the incision, they really stay right there. So I'm going to make a small adjustment here. Now there's about 15 degrees between the incision and the edge. So this looks just about where we want it, applicator. And then the key is, I'm fairly aggressive about just trying to smooth it out. Look at the green light. Just to let it kind of take its form through the channel. Now, one of the nice things is if you're working in a 360-degree channel where you may not have the two incisions to work just as close to one another, you can really smooth the inlay out and actually move it towards the edge without actually pushing the inlay all the way. So that's a nice trick if you're not as close to the inlay through the incisions. But I really do like having the two incisions to work with because it really does make getting the inlay into position very straightforward. Look at the green light. Find the green light for me. Do you see the green light? There we go. So this is really perfect positioning. The inlay really is right where it should be, right around our 4.5 millimeter mark. And that's it. The entire C-Tech is placed and ready to go.
Congratulations. What a beautiful case here.
Yes, so any other questions?
What was the last instrument that you were using, the round one that looked like a little iron? Can you show us?
Yeah, we call it the C-Tech. I'll show it to you in a second. We call it the C-Tech applinator. It's very similar to. It's very similar to like when you're ironing out the applinator. When you're ironing out folds in a LASIK flap, it's designed a little bit wider so that it really can encompass the entire C-Tech channel, and it gives a nice ability to kind of smooth circumferentially and really get the inlay very smooth within the channel itself.
Do you ever put, sorry, this is Marjan from
Yes.
Do you ever put a suture through those incision ports?
So look down, gently close. So I don't. I really find that these inlays never move. I've had them even within 5 degrees of the incision, and I've never had a problem from it. Fix our contact lens, but I've never had a problem from it. The only time, and even when we've used, these can go as long as 330 degrees. And when even they're 330 degrees, leaving about 15 degrees on either side, I don't find you need a suture. The only time I've ever really sutured is if I've seen a small tear potentially at the flap edge, and felt that it wasn't going to settle down in position, but that's very, very rare.
Hi, this is Sophie Dang. Could you tell me about a very nice surgery. Could you tell us about what's your post-op care for these patients?
Sure. So we use 1 week of antibiotics. We put them on moxifloxacin generally for a week. And then we use pretty much our cataract post-op regimen where we taper a steroid weekly for 1 month. So we go 4, 3, 2, 1 over the month. When I started doing CTAC, we used more of our DALK regimen where we would keep them on steroids actually for about 6 months. Then I reduced it to 3 months, and over time we were not seeing any significant inflammation. So 1 month has worked very well. I think probably we could even reduce it a little bit from there. There's really very little inflammatory reaction to this tissue at all. And to date, I haven't seen any rejection of it.
Hello, this is Enrique from Mexico. Congratulations on the surgery. Can you tell us more about when does the refraction get stable, and how often do you do topography in these patients, and how do you follow them across the procedure?
Yeah, sure. So generally, actually, if you're not doing cross-linking with the procedure or after the procedure, which we do sometimes, I do the first refraction between 4 and 6 weeks. I think that there's such a gross effect from the inlay. In our initial trial, we saw that the spherical equivalent went from about -6.25 to -1.5 on average. And that effect happens over the course of even 1 week. So you can give them their first refraction, and if you're going to give them a pair of glasses at about 4 to 6 weeks, there is epithelial remodeling that happens over 6 months, as we know from all these procedures. So I think there is some refinement of that prescription down the road. But I will give them the first prescription around 6 weeks, and then in 6 months I kind of reassess it. With topography, I do actually an immediate topography now, just to look at how I think the edges have aligned with the cone. We do our first topography usually at the 1 week appointment, and then we do it at a month, 3 months, 6 months, and a year. That's our kind of general follow-up with the inlays. Now, in terms of contact lens fitting, I start them very early if they're going to wear a scleral lens still afterwards, because I think that the incisions are healed very quickly, the inlay's in position very quickly, and getting a scleral lens can take even a few months to get to the final fitting. So after about 2 weeks, I will have them see our contact lens fitter to actually start that process, because I don't think they're actually getting their refraction at that point anyways.
So do you modify your regime or the algorithm if they had cross-linking before, or they're planning to do cross-linking after?
No, so I don't. I mean, I think that nowadays we really do the cross-linking after. We do it on a lot of our patients who had cross-linking before historically, but we generally do the CTAC first, and either we do cross-linking the same day or we do it a few months after, depending, sometimes on a month after, so depending on logistics. Most of our patients now have it done the same day. I don't find that you have to modify the algorithm much, because the algorithm right now, and this is a very important point of the algorithm is not accounting for preoperative refraction. So the algorithm is trying to create a more regular shape to the cornea. So unlike doing like a topography guided PRK or something like that, where a diopter and a half of additional flattening from cross-linking would potentially affect your treatment, I think it's very unlikely that the average flattening of cross-linking, especially over the first few months, which is going to be at most 2 diopters and usually average around a diopter and a half, is going to affect the final outcome. I would say that if you are looking to do this in extremely mild cases, 50 diopters or less, then you might want to consider, that would be the only case you might want to consider doing the cross-linking first, because a diopter and a half of flattening there would make a big difference. But we're really not recommending starting with that mild of a case for CTAC at this point.
Hi, it's Carol Cart from Bascom Palmer. Beautiful job.
Hi.
And also great explanation, so thank you for the whole audience here.
Absolutely.
Out of curiosity, do you notice any difference in rigidity for those cases that were cross-linked before rather than after, or is it just indetectable?
It's indetectable, yeah. We're asked that question a lot, I've never noticed a difference at all. So I'm not hesitant to do it after cross-linking. I still think cross-linking does provide biomechanical strength, but it's not. You can't tell. At least I can't tell when I'm doing the surgery.
I have a question. Okay.
Yeah.
Good surgery, good job, Steve. And is there a nomogram, different nomogram for central or paracentral peripheral keratoconus? And my curiosity is, do you lose effect over the time, which is the time of the maximum effect, the efficient of the inlays?
Yeah. So in terms of the nomogram does take pattern and location into account. Right now, we recommend using CTAC when the bulk of the cone is within the central 6 millimeter optical zone. You can use it in cases that are more peripheral as you get more adept to the inlay, but there is more changes that you may have to make manually to the algorithm as you move into like a more pellucid pattern. So right now, especially in early cases, we recommend sticking to cases where the inlay really is in the central 6 millimeter, at least like I said, the majority of the cone is in the central 6 millimeter optical zone. And the other question was, remind me?
If you lose action.
Oh, lose effect over time, yes. So I just saw actually someone who had CTEC done now by me almost 4 years ago, and the effect had not been diminished at all. The refraction was stable, and the topography was stable as well. So we're just starting to see our earliest cases that we're doing with this version of the inlay and this algorithm, which really started around 2019 and 2020. We're starting to see those patients kind of hit their 5-year mark. And of the ones we've seen so far, we have not seen a diminished effect.
Thank you. And
you do get a diminished effect over the first week. So when we do put it in now, we're going to see cornea's edematous, we're going to see more effect than we're going to see a week from now. But past that, we're not seeing diminishing effect.
Well, Steve, thank you so much. We have to move on with the program, but beautiful surgery. We really appreciate you taking the time, and we want you here in Italy next year live, okay?
Sounds great. Well, thank you for inviting me to do this. This was a lot of fun. Enjoy the meeting.
So let's bring up our first speaker, Dr. Basu, talking about stem cells, hydrogels, and 3D printed cornea.
Good afternoon. Thank you so much for the opportunity. So I'm going to speak to you about corneal stromal regeneration, which I think nicely segues into the life surgery as well, because we're talking about stromal pathology. So I have the following disclosures, a few patents on the products I'm going to talk about and the sources of funding. So where I come from at LV Prasad Eye Institute in Hyderabad, we have over the last many years invested a lot of resources in building this translational research pipeline, which is for bench to bedside research, which includes the wet labs for basic research, the 3D bioprinting facilities for organ on chip and in vivo validation, the zebrafish facility, the GMP manufacturing facility, animal labs, compounding pharmacy, and also a clinical research center for doing the clinical trials. And a lot of the work that I'm going to show you is because we have this research pipeline and we are able to do this kind of translational work. So we also try as much as possible to adhere to the very demanding guidelines for this kind of research with regeneration, stem cells, biomaterials, and also kind of identify and focus on problems which are relevant to our population, where we have the opportunity for using regenerative therapy to bridge a gap which exists currently, and of course find a solution that is affordable and practical and not a $1 million product that is out of reach of most people who need it. So why are we focused on corneal stromal regeneration? Because in India and in most of the developing world, unlike in the West, in Europe and in the United States, endothelial disease is rarer, and stromal causes, particularly stromal opacification because of scarring from infections and trauma, is the #1 cause of corneal blindness. And unfortunately, corneal transplantation does not carry as good a prognosis in these indications as it does for endothelial diseases and for endothelial transplantation. So we have to find other alternatives, and of course there are so many ways to approach the same problem. What I'm going to talk to you about today is what is on the right side of your screen: stem cells and bioengineering with biomaterials. So if you think of the stroma, it's actually a very simple structure. It's a vascular, it has very limited cellularity, but the cells that are there in the stroma, the keratocytes, are of mesenchymal origin and essentially produce the rest of the extracellular matrix. So if you think of stromal regeneration conceptually, you can either work with the keratocytes, which are the cells that make normal stroma, or work on regenerating or producing the extracellular matrix itself, or you can have a combination of both these approaches where you have both the cells and the extracellular matrix. So you can think of the cells, the extracellular matrix as the gel, and together the cells plus the gel. Before we start to look at the different options, therapies, and their outcomes, we also have to find a way in which we can objectively quantify what we're trying to treat. because a scar, an opacification because of a scar is not just the opacity, but it's also thinning of that area, there's irregularity and this flattening. So if you are going to restore vision to an eye which has been blinded because of scarring, you have to fix all of these problems. Just making the scar go away is not going to help. And keratoconus, like we just saw, is a perfect example of this, where you have a clear cornea, but the patient can't see because the cornea is irregular and you have a lot of astigmatism. So first, let's talk about cells, keratocytes, and this is based on seminal work done by my mentor, Jim Funderburg at the University of Pittsburgh, where they discovered the MSCs at the limbus, very close to where the limbal epithelial stem cells are, in fact, just next to them in the stroma. And there are very many ways of getting these cells, and the good thing about these cells is that, like all other MSCs, they have anti-inflammatory and also wound healing properties. So you can use them in conditions where you have a lot of inflammation and you want to take care of that, or inflammation has led to extracellular matrix deformation and that needs to be treated. So we've just completed a 2-year follow-up on 2 Indian FDA regulated trials where we used these cells for treating superficial corneal pathologies, which included corneal scars, ulcers and burns. We used 2 approaches. One was the unpreserved cells and also the alginate preserved cells. Alginate preservation is a very interesting form of preservation. Alginate is essentially nothing but what you have in sponges or in tampons, and it essentially just absorbs water. But what it helps us is, the way that it helps us is that you can preserve these cells in a very uncomplicated way and also extract the cells from them by just spinning them down without having to maintain the cold chain. So this significantly reduces the cost of therapy because you don't have to transport the cells maintaining a cold chain, which is extremely expensive, prohibitively expensive. So we had to do the preclinical animal studies showing the safety of these cells in 2 animals, the efficacy of these cells both in an active wounding model and in a formed scar, which showed that application of these cells could improve corneal clarity and stability and vision. And then we also had to find a way in which we could produce these cells in a xeno-free and serum-free, which means that it's safe for human use. I'll just show you how we get these cells and how they're manufactured. So these are from corneoscleral rims from the eye bank, usually what you throw away after doing a DALC or a PK. And this is the limbus is obtained from this, chopped down, digested, and then these cells are incubated. And initially when they grow out, because this is a mixture of epithelial and stromal cells, you get both. But with serial passaging, you can get a pure population of the limbal MSCs. And this is what is then sent to the operating room to me to apply to the patients. And I'll just show you a very brief surgical video of how this is done. This is under topical anesthesia. The cells are mixed in one of the components of commercially available fibrin glue. And then we essentially just topically apply this on the surface. So here you've seen I've removed the epithelium with a sponge and then just sandwiching the 2 components of the glue to put the cells in. And it's a very short procedure. At the end, you put a bandage contact lens on top. And in the clinical trials that we did, these patients just received prophylactic antibiotics without receiving anything else, no steroids. And I'll show you some of the outcomes. So in general, you see clearing of the scar with time, also improvement in the surface regularity. This is one of the examples. This is a phase 1 study, so mostly focuses on safety, but we did see good efficacy as well for formed scars. This is a 2-year post-op, and also for this patient who had Hansen's and neurotrophic keratitis. I showed this slide yesterday as well, where a single application in a patient who previously failed amniotic membrane transplants and tarsorrhaphy led to this kind of a healing response without scarring or haze or opacification. So the last bit, I'm going to focus on the extracellular matrix and what we can do with it. So the cells I've talked to you about. The extracellular matrix is basically the product that the cells make, but you can also get them from discarded corneas. And you essentially basically lyophilize them, powderize them, and use this powder to make a hydrogel, which is sticky, which can be applied on wounds. So any kind of corneal laceration or corneal ulceration, it can be used. And these also have wound healing properties, as we have shown in preclinical studies. We are about to start the clinical trials with this hydrogel this year in October, actually. And finally, if you use them together. So this is where the concept of 3D bioprinting comes in. And bioprinters essentially use some kind of a biological material as the ink to print shapes. And here we use the extracellular matrix that I just told you about to print corneal shapes. So you can either use an extrusion printer that you see on your left, which uses a mold. So the mold is in the shape of a cornea, and then the excellular matrix is just used to print a cornea on top of that mold. Or you can also do light-based bioprinting that you see on the right side, which is more customized and more personalized for the patient. You do a modeling of the cornea based on your topography or your anti-segmental OCT scan, and you can print corneal lenticles. Not only can you print the entire corneal substrate, but you can also print small segments like we saw for the CTAC. You could do personalized segments for using in patients with irregularity. These are currently in preclinical trials in rabbits, where we are doing the safety studies using these 3D printed lenticles and looking at their safety. So we are hopeful that sometime next year we will be in clinical trials with the 3D printed cornea. What we are also very happy with this cornea is that it has the elusive combination of transparency and strength, so that you can suture through the cornea without it cheese wiring or breaking, which is in bioengineered corneas is very, very difficult combination to achieve. So this is where we are right now with cells. The safety and efficacy is what we are looking at right now. These are in clinical trials. There are many other groups who are working on MSCs from other sources who have also shown significant efficacy in different kinds of stromal pathologies. And in the long term, I think we are looking at cell therapy, not just for the endothelium, but also, and not just for the epithelium, which has been around for so many years, but also for the corneal stroma and for inflammatory conditions. Hydrogels for wounds and other forms of trauma and ulceration for scarless wound healing. And these customized, personalized 3D printed lenticules, not only for replacement, but also for refractive procedures and for keratoconus. So before I finish, I just want to thank all my collaborators, some of whom are here, and my fantastic team back in Hyderabad, and thank you so much for your attention.
Very, very impressive questions. So,
sorry. Yes, always impressive every time I hear a talk. The question about why you put the cells in the hydrogel, don't you think that when you put a hydrogel without the cells, the whole cells will migrate and populate it?
So the hydrogel does not have the cells. The hydrogel is acellular. It's just lyophilized corneal excellular matrix. So we use tissue that is discarded, either after keratoplasty, so the corneal rim, or corneas that are not used, not optical grade and not used for transplantation, but otherwise are biologically safe.
The wrong name. I'm talking about 3D printing. So
okay.
The 3D printing is the same concept as hydrogel.
Right.
Right. And why? What do you think the advantages are for putting the cells in the printing?
Right. So you could potentially have 3D print the excellular matrix without the cell. But if you wanted to incorporate the cells, not just the stromal cells, for example, if you wanted to print epithelial cells on them, you could do that too. If you wanted to print endothelial cells on them, you could do that as well. So you can actually print the entire cornea as it is anatomically supposed to be, with epithelium on top and stroma inside the excellular matrix and endothelium at the bottom.
Cyan, beautiful work. Have you applied more than once, or is it just one single application in the cases that you showed us and then others? And the other question was, in total, how much do you think each application or treatment for a patient costs?
So that's two excellent questions. The first is, for our studies, because these are highly regulated, it's a single application. But once it is approved therapy, I think that you'd have more flexibility, that you could use multiple times. But you have to remember that these are allogeneic cells, so you can't use them too many times, because you might then start inciting an immune response. But potentially you could use multiple times, but for the studies this was all single application. And the second question was about, sorry, I forgot. What was your second question, Clara? The cost. So we are trying to keep it to a minimum. So, like I talked about, storage is one important factor. Having the 3D printed technology developed indigenously is another factor. So we want the treatment to be less than $100 a pop for the patient.
Simon, two questions. One is, do we know what happens to the cells after they're transplanted? What's the fate of these cells in the long term? One question. And the other is, did you find any difference in the donors that you took out the cells from?
So The cells, what we know about the mechanistic aspect of how they work is that they don't hang around forever in the tissue. Mostly it's paracrine effects from what the cells secrete. So there's also a lot of smart researchers who are working on that, on conditioned media, on exosomes, on the different products that the cells make instead of focusing on cell therapy itself. But I think it's a combination of the things that the cells make. So the cells don't survive beyond like 6 weeks. Beyond that, so whatever other paracrine factors that it secretes and how it impacts the local milieu is how the tissue regenerates.
So 6 weeks they last on the ocular surface and then they vanish.
That's what we know from previous research on preclinical work.
In terms of the donors, when you're for the donors that you're extracting the cells from, is there any? So is an old donor the same as a young donor, or?
I would, I think that there would be differences based on donor characteristics, particularly age. We haven't, looked at that in terms. So we have like for all stem cell trials, there is a release criteria and a quality control criteria that you have to meet, that they have to express a certain amount of factors and that they have to be sterile, etc. But I'm sure that there would be minor differences based on donors as well. I'm sure that younger donors would have more potential than older donors.
Thank you for that wonderful presentation. Let's move on to our next talk, Dr. Kossler, talking about advances in corneal keratinization.
Thank you so much for having me today. I am an oculoplastic surgeon, director of the service at Stanford, so I'm going to take us kind of looking at things a different way here. So I'm going to talk about corneal neurotization and a little tip on how we can all get started for this procedure. So my financial disclosures are not relevant to this talk, except that I am the editor for the Techniques in Corneal Neurotization book. Okay, so when I first wanted to start doing this procedure back in 2015, my cornea colleagues thought that this was completely crazy. And they wondered, why would we do corneal neurotization? How would this exactly work? So it makes complete and total sense to do corneal neurotization. We know that the cornea requires sensory nerve input. We know that the sensory nerves evoke the blinking and the tearing reflexes, which are so important for the protection of the ocular surface. The nerves release important neuropeptides, which are critical for epithelial cell integrity and maintenance and turnover. And in return, we know that the corneal epithelial cells release important growth factors such as the neurotrophic growth factor, which is critical for corneal nerve function. So we know that there's a symbiotic relationship between corneal nerves and epithelial cell health. Without sensory input to the cornea, patients will develop neurotrophic keratopathy, which of course can result in poor vision and poor outcomes. Now, when I think about neurotrophic keratopathy as an oculoplastic surgeon, I think about the etiology of the cause. So is this postganglionic? Is this distal to the cell body? Or is this preganglionic? Is this central? Is this proximal to the trigeminal ganglion? Because I think that that really does matter and helps us to select the proper patients. So we know that sensory nerve input is the problem in neurotrophic keratopathy. What if we could restore nerve function to the eye? Well, we know, of course, that we can do that. We know the peripheral nerves can regenerate when they're cut or damaged. If you cut a distal axon, then that distal stump will undergo Wallerian degeneration. And it'll send a signal to those proximal Schwann cells to proliferate and to support axon myelination and regeneration at about a rate of 1 millimeter per day. So neurotization essentially harnesses the power of the peripheral nervous system and guides those regenerating axons to the target of your choice. Now, this approach was first popularized by Therese et al. In 2009, where she first described direct nerve transfer. She took the supraorbital and the supratrochlear nerves and directly transferred them to the cornea. Since then, the indirect nerve approach has been popularized. This is where you leave the donor nerve in its place and you attach a nerve graft to the donor nerve, and that attachment is called coaptation. You can do that end to end, where you're just cutting the donor nerve on its end, or you could cut a window on the side of the donor nerve and you can attach your nerve graft end to side. And so the surgery looks like this. You have an intact and normal side. This is the left side, and you have a healthy donor nerve. We're using the supraorbital nerve here. You cut the supraorbital nerve at its end, you attach the nerve graft, and then you tunnel that nerve graft to the cornea. And those regenerating axons will travel down your nerve graft, kind of like water going down a hose to the insensate cornea. So we know that a healthy nerve requires nerve input. We know that peripheral nerves can regenerate, and neurotization is a technique that has been used for decades to guide regenerating nerves to a target. And so let's talk about how we can get started. First tip is to select easy cases first. I recommend stage 2 and 3 neurotrophic patients. You do not want to do surgery in patients that have significant conjunctival scarring, blebs, active infection, or inflammation. And I recommend that you start with a unilateral transfer first, which means that you're doing the transfer with the donor nerve on the same size as your insensate cornea. But any level of neurotrophic keratopathy patient could be a candidate, but you certainly wouldn't want to pick someone who's receiving radiation, who has any risk of malignancy in their donor nerve, or who has active infection or inflammation, because nerves do not want to grow into that environment. Tip number 2 is to start with indirect transfer first. And so that means you're using a nerve graft. And I recommend that you use an allograft if you have it available. These are essentially off-the-shelf grafts that are cryopreserved, decellularized cadaveric nerves that basically serve as a matrix for your nerves, your regenerating nerves, to grow down. This will decrease the surgery time. You don't have the expertise to harvest that autograft, and you don't have the second site morbidity. But you'll eventually graduate on to harvesting the autograft, and my favorite is the sural nerve, which travels along the back of the leg to the lateral ankle. And these are nice because they're very long, so you can do unilateral or you can do contralateral or bilateral surgery. And these nerves also have Schwann cells in them and other growth factors, and it's thought to be better for longer distances. Tip number 3 is the donor nerve that you select. It's very important that you select a donor nerve that has a lot of axons. So I prefer the supraorbital nerve because it has 6,000 axons as it exits the supraorbital rim, and you need at least 900 myelinated axons to have a successful neurotization. But we have many options on the face for your donor nerve, including the supratrochlear, the infraorbital, the mental, the greater auricular nerve, so many options. The next tip is the proximity. Closer is better. Try to get the closest donor nerve to your insensate cornea that you can. And we also care about diameters. If you're going to do an end-to-end coaptation, you want to make sure the diameters are similar in size. Tip number 4 is how we isolate the supraorbital nerve. So this is just a blepharoplasty style incision, which we all learned in residency. So you make a blepharoplasty style incision, you dissect underneath the orbicularis muscle to the orbital rim. All of that happens very quickly. Once you get to the center of the supraorbital rim, then you will dissect in a pre-periosteal plane. Here I am just dissecting medially to expose my supraorbital nerve. You can see how large that nerve is as it exits the supraorbital rim, about 2.7 centimeters from midline, and I hook it with a 4-0 silk suture. Tip number 5 is to use a right needle, which is common in congenital ptosis surgery, through the superior fornix. And then you take your nerve graft, you bring it to the superior fornix, and you tunnel it in a subtenon's plane to the corneoscleral limbus. You separate your nerve graft into its different fascicles, and you bring each fascicle to the respective quadrant. Now, you can suture the nerve to the corneoscleral limbus, but I have started just using Tocil alone, which is a fibrin glue, and other people will use scleral tunnels. Studies have demonstrated no difference in the efficacy. Tip number 6 is to perform your coaptation as the last step. This is when you're suturing your nerve graft to your donor nerve. As I mentioned, you can do that end to side, where you cut a window in the side of your nerve, but I recommend that you start doing it end to end. End to end, you're cutting that donor nerve on its end, and so therefore, more axons are going to need to regenerate, and more axons is better, especially when you're starting to have an effective neurotization. Tip number 7 is to utilize your coaptation adjuncts. There are many things that we can use to support the coaptation site. One of the adjuncts that I like is the nerve connector. And so this is what the video shows me suturing the nerve graft to the nerve connector. And then I'm going to cut my nerve connector. Here I'm cutting my donor nerve on its end, and then I'm suturing that into the nerve connector, leaving a millimeter between the two segments so I have a tension-free free coaptation, and then I use a little to seal there to support that union. You can also use amniotic membrane wrap, you can use a nerve wrap, you can use anything to cover that coaptation site to prevent fibrosis and inflammation at the coaptation site. Tip number 8 is to be patient. Axon regeneration takes time. It's going to take at least 2 to 3 months before the nerves arrive to the limbus. Another 3 to 7 months before the nerves grow through the stroma and neurotize the superficial central cornea, and even up to 24 months before you have complete neurotization. However, the procedure does work when you select the proper patient and you have the proper technique. In a review of 70 eyes, we found significant improvement in vision, significant improvement in corneal sensation using the Cochet-Bonnet anesthesiometer, improvement in wound healing, and we didn't find any difference in the approach, the donor nerve selected, or the graft type selected. Over a dozen studies have now demonstrated anatomic evidence of nerve regeneration using confocal microscopy with durable efficacy of up to 5 years so far. So in conclusion, corneal neurotization, it's safe and effective. It can restore sensation to the cornea, improve wound healing, and improve vision. And there is long-term anatomic evidence of nerve regeneration into the cornea. However, of course, proper patient selection and proper technique is necessary. And thank you so much for your attention. Happy to take any questions.
Thank you.
Thank you so much. That was beautiful surgery. Question for you, or anybody who's doing neurotization, have you found any additional benefit to having a round of Oxervate along with this?
Yeah, that's a great question. How many people in the room are doing neurotization with their, plastic surgery, oculoplastic surgery, or other colleagues? So yes, I think that we have a group in the United States and we kind of share our cases together, and I definitely think that Oxervate can be helpful. The question is when. Because it does take a while for the nerve, it depends on how far your donor nerve is. It takes time for the donor nerve to get to the ocular surface. And so I don't necessarily think you want to do the Oxervate at the time of the neurotization, but we've done a couple, we're trying different things of trying to start the Oxervate maybe 2 months into it, because we do think it takes some time for the nerves to get there. So I do think it can help. We don't quite have any, randomized studies to prove that it does, but it does make sense. There are also other adjuncts that you could consider that could help with the neurotization.
Very nice presentation. Do you see any difference in terms of how far you tunnel the nerve into the cornea, and whether you tunnel further in will decrease the time of innervation?
Yeah, so there's been a lot of work done on scleral tunneling. Greg Borschel and Azam Ali have done probably the most work when it comes to using scleral tunnels or not using scleral tunnels. In our conversations, at least talking with Greg Borschel, we don't think there's a big difference. So when I first started, I was doing these procedures with my cornea specialist, and we were doing scleral tunnels. I was a little worried that we were crunching the end of the nerve and, having to push the nerve into the scleral tunnel. I worried a little bit more about the damage we were doing to the end of the nerve using the scleral tunnels. It still did work, but we don't have wonderful outcome metrics is another major problem that we're dealing with this surgery. So we started with scleral tunnels, and then as I started to do this without my cornea specialist, I started to suture it to use the epinurium and suture it to the corneal scleral limbus, and then more recently, I've just been using to seal, and it seems to be working just as well. And in my opinion, using the to seal is probably the best option because I'm not damaging that nerve.
Many of our patients have NK and they need a subsequent keratoplasty. Is there a time frame when you wait after this procedure before you recommend?
Yeah, that's a great question. So I did have one patient fail. And I think it was the cataract surgery, because I went from doing 4 fascicles to now only doing 2. And my 2 fascicles go in at 3 and 9. And when they had the cataract surgery, the surgery was done about 2 months after the surgery, and the incision was in the area where I had placed one of the nerve fascicles. And so I don't know why the surgery failed, but that was my opinion. So I now ask people to wait 6 months, because I do want the nerves to be able to not only grow to the corneal scleral limbus, but then try to repopulate the corneal stroma and get to the superficial cornea. And studies have demonstrated that when you do neurotization, the nerves are not in the normal arrangement as before neurotization. It's not the same quality, it's not the same quantity, so we're still trying to learn how to make it better, but we definitely do see that nerves arriving there. So I asked my cornea specialist to wait 6 months. However, there is another oculoplastic surgeon named Ilya Langold, and he's probably done hundreds of these cases by now, and he has done corneal transplant at the same time as neurotization. It just doesn't make sense in my head, so I don't do it. But, you know, they've had some good results. I think Victor Perez and him have worked together on this.
Congratulations. I would like to know how many connections do you do in limbus, and how many? How much do you recommend us?
Yeah, so when I first started, I was doing 4 fascicles because, you know, that's what was published. Now I only do 2. Greg Borschel and Asim Ali, who have probably done more cases, they've done at least 75 cases that they've published. They did a study looking at the number of fascicles, and they actually found that if you do 3 or more, it's detrimental. And so now they say 2 or 3 is kind of the best option. And so now I'm actually doing 2. So it depends if I'm doing an autograft or not, but if I'm doing an autograft, I want to use all of those fascicles because I don't want to damage the nerve in the wrong spot. So I'll just separate it into 2 big trunks and put them in at 3 and 9, but I try not to discard my nerve, if that makes sense.
Thank you.
Did you observe any differences between patients that have pre and post ganglion lesions?
So yeah,
because I think there's a big difference with senesamine.
With what?
With senesamine, eye drop, and nephrophytic eye drops.
Yeah, so if your question is it matter if it's preganglionic or postganglionic, central or not? So in my opinion, if a patient has earlier, and I'm not a cornea specialist, but if a patient has earlier neurotrophic keratopathy from a central origin, I think we should do the neurotization because I don't think that the nerves are going to grow back. However, if they have neurotrophic keratopathy from some peripheral reason, well, then I think it makes sense if they have a stage 1 or a stage 2 to try everything else first, right? So I don't mind doing neurotization on a stage 3 patient if they have a peripheral injury, but if they have a central injury, it doesn't make sense to me to wait. And I haven't seen Oxervate work in those patients, but again, I'm biased because I'm an oculoplastic surgeon.
Have you observed exaggerated results like hypersensitivity or pain or neuropathic pain?
That's a great question. I had a patient that I actually canceled because I was just too worried. She already had intense pain, and she already, the wind and everything would cause her to have pain. She was sent to me because nothing else was working, and it was thought that if we could bring nerves to the ocular surface, we could improve the milieu of the ocular surface. And some of the other doctors that I work with have done it on patients that have hypersensitivity, and they think that it works. I got worried, and I canceled her case. So I'm very careful about patient selection. I like happy patients. I haven't had a problem with it. I have colleagues that think that you can do neurotization even in patients that already have hypersensitivity. But the problem with neurotization, and the reason why I don't think that it's really gained favor as quickly as we hope, is that if you select the wrong patient, it's not going to work. And we don't have a ton yet of outcome measures to really tell us what's happening. We are working on it. But right now I haven't had that problem because I haven't selected patients that I think I'm at risk for having that problem.
Great. Thanks very much. Wonderful presentation. We're going to move on with Dr. Free talking about approaches for contact lens-related ocular surface disease.
Wonderful. Thank you so much to the organizers again for having me here at this wonderful meeting. So we're going to switch gears a little bit, and there's so many things with contact lens where that can occur in terms of complications that we all have to address, as simple as some perilimbal inflammation and injection. Obviously, infectious keratitis from contact lens, where we've heard a lot about that with acanthamoeba keratitis and bacterial keratitis. Patients can get poor sensitivity to contact lens, where inflammatory lid reactions like giant papillary conjunctivitis, and then with long-standing contact lens wear and chronic hypoxia to the limbus, limbal stem cell deficiency from contact lens wear. Most often, these contact lens wear problems come from long-term use, and these are often patients with very high refractive errors. These are patients that absolutely love their contact lenses, They hate to wear glasses because they're either very myopic or very hyperopic. And the contact lens wear often will mask the symptoms, which leads to more contact lens wear and then continued ocular surface insult, and it becomes a vicious cycle. So they're irritated, they're inflamed, they're red, they put their contact lens on, it gives them a bandage contact lens effect, and so they're miserable when they don't have their contact lens on, and this sort of prolongs this insult to the ocular surface. And these patients are often managed at the optometric level with attempts to change contact lenses, using more contact lens types that allow more fluid to the surface of the ocular surface, but often, or switching to daily wear, but often, again, they stay in the optometric practices for a long time before they're finally referred to cornea practices, and by then the sequelae can be severe. We published this article on young patients. These are patients who, actually not patients at all, these were young, healthy medical students and residents. We did my biography on all of these young people and found that the significant association with meibomian gland dropout related with contact lens wear. So in the young population, you start to see the effects on the ocular surface health very early on. Contact lens related stem cell deficiency is an issue that we see not too infrequently, again, with these patients who are high myopes, chronic contact lens wears. Some of these patients may have an underlying niche problem, because on the flip side, we have patients that we see have been in contact lenses for decades and they do fine, but I've had patients who are very young, may have just worn contact lenses for a few years, and they come in with limbal stem cell deficiency. So I think there is some underlying potential genetics related to the limbal niche that makes some patients more susceptible to the hypoxic damage. But again, these patients come in with conjunctival injection, often very inflamed. They don't want to stop their contact lenses. The early signs we'll see is that the architecture of the limbus is often altered, and the limbal anatomy is obscurated, followed by irregular fluorescein staining pattern. And this is really the hallmark. Dr. Sarnicola, Enrica described this earlier. You get columnar and whorled epitheliopathy that you see in the later stages. And then very, very late stages, of course, with limbal stem cell deficiency, you get conjunctivalization of the cornea, poor healing defects, and symblepharon issues. But often we'll see a patient, they look like this. By the time they get to our offices, they're miserable, they're injected, they're highly inflamed. And again, you can see subepithelial haze starting to form in the areas where they've had this chronic whorled epitheliopathy and conjunctivalization of the ocular surface. Epithelial breakdowns can be very common, and these may often get misdiagnosed as recurrent herpetic disease. Some of these eyes get mismanaged, topical antivirals are introduced, which can exacerbate the issues as well. So my rule of thumb is if the epithelium doesn't heal with 1 to 2 weeks of antiviral treatments, rethink your diagnosis, especially in contact lens wearers. Our own Dr. Jalilian, who's here, published this beautiful paper along with Ed Holland here, really discussing that a lot of these patients with contact lens induced limbal stem cell deficiency, you can medically reverse them if you're aggressive and you start early, and often that begins with getting these patients out of their contact lenses, which again, a lot of these patients absolutely hate to do. I stop all drops that have BAK, switch any pressure lowering drops to preservative free, or actually advocate for earlier glaucoma surgery in patients who need to be on pressure lowering drops. These patients are often very, very inflamed, so using a tear film inflammatory marker, those are often positive, so steroids are a huge help in these patients to immediately quiet down that inflammation. Long-term immunomodulators are also very effective. In terms of contact lens wear, again, I often switch these patients to scleral contact lenses, and we'll talk about that in a minute as well. Autologous serum drops or super serum, PRP in certain instances, we now have a lot of evidence showing improvement in patients with neurotrophic keratitis, with patients with severe dry eyes and ocular surface disease. You can really customize these and create 20%, 50% or more strong serum. I actually start these patients on a 75% concentration to really get as much of the growth factors of the serum to the ocular surface quickly, and then I may bring them down to something like a 20 or a 50%. Previously, we'd have to collaborate with a lab and a compounding pharmacy to produce a sterile product. Now, at least in the US, we have some national groups that produce these and send a phlebotomist to the patient's house and make it very, very straightforward and simple to get. Amniotic membrane is also another adjunct in these patients to try to reverse or at least give some nutritional, anti-inflammatory, and regenerative properties back to the ocular surface. They come in different forms. I feel like the fresh frozen is probably the most useful in terms of getting some of those anti-inflammatory properties to the ocular surface. Again, several papers looking at using cryopreserved amniotic membrane for treatment of corneal ulcers as well as immune-related ocular surface disease. And then scleral contact lenses really are a big favorite for me in these patients because they want to go into contact lenses. The only caution here is that these need to be fit very well, because if they're fit too tightly, they can further exacerbate the hypoxia at the limbus. So really they need to be fit well, but these patients really do well with long-term scleral contact lenses while their limbal niche recovers. Surgical management really reserved for the worst of the worst. You can't really use the other eye if both eyes have a history of contact lens wear. So often if I have to move to surgical, I'll go to a living-related conjunctival limbal allograft. This will require immunosuppression as well. Dr. Holland and Dr. Chan have described limbal stem cell transplantation for patients with contact lens-related stem cell deficiency, and often early intervention can minimize the risk of having long-term haze and subepithelial fibrosis occurring in these patients. Living-related conjunctival limbal allografts are better than keratolimbal allografts from a cadaver. This has also been published by Dr. Albert Chung and Dr. Sarnacola and Holland. Harvesting, again, now this is, I showed this video yesterday. This was harvested for a different reason, but you don't need as much conjunctiva harvested in contact lens related, but you can see just the technique that is done dissecting about 1 to 2 millimeters into the cornea to really capture those limbal stem cells. You only need a small piece in patients who have contact lens related. And here we come to the diseased eye, and what I do is I take about 3 clock hours from the superior, 3 clock hours from the inferior, reconstruct them here. The 3 and 9 o'clock areas, then what I'll do is I'll use some amniotic membrane to reconstruct those areas so that there's no gap zones. And that allows enough time for the stem cells from these donor conjunctival limbal allograft segments to populate the cornea. And so you can see the amniotic membrane filling in here. So this is a 61-year-old woman. We treated her medically for about a year with not much resolution, and we finally went to a conjunctival limbal allograft, and you can see a beautiful resolution and improvement in her vision. So identify these early, remove the offending agents. Management of the inflammation is really critical. In some cases, we'll need surgical intervention. Thank you.
Thank you, Marjana. Questions? Carol or Enrique?
Yeah, very nice talk. I was surprised to see that you've used autologous serum tiers at 75 and 100. I go to 50, QID, and then PRGF. So tell us, who makes that for you? How often do you apply it? Are there any downsides that you've seen that, never used that.
A really great question, and I don't think there's any evidence showing one percentage being better than the other. So some of this is I feel like I want to get as much growth factors to the ocular surface. I used to use 100%, but we'd get clotting at the tip of the bottles, and so patients got frustrated because you actually get a little bit of clotting of the plasma. So we went down to 75%, so we were still giving them a good concentration of that growth factor. I start very aggressively, at least their first round, every 2 hours, if they can. I say when you're home, because this needs to be refrigerated, use this every 2 hours. And then, I tell patients, it took you many years to get to this point. It's going to take a long time for us to see some recovery and some of that world keratopathy that's occurring centrally to regress back up or down towards the limbus and get a clear zone centrally, which is ultimately our goal. So, depending on how quickly they're responding, I will decrease the concentration so that they can have more product as well. But following no evidence at all on that, but in my hands at least, that seems to work really well.
So I think purely contact lens related stem cell deficiency in the early stages is usually asymptomatic. When it's late and with comorbidities with dry eye or other things, it's a different thing, but purely contact lens related stem cell deficiency in the early stages, it's very clinically subtle to detect it. So how often do you follow these patients? What kind of tests do you do on these kind of patients?
Yeah, absolutely. So a lot of these patients, you're absolutely right. They don't even come to our practice. They're in the optometric practices and they're not getting stained to look for this. They might complain of a little bit of irritation, dry eyes, their contact lens type gets changed. They may be placed into dailies, but it doesn't really get into our offices until they have severe visual sequelae.
Or they're buying their contacts online and don't have any eye exam.
Exactly. So these often get missed until they're pretty late in the stage, absolutely.
Great, very nice talk. And one question is that we just published a paper showing that the coexistence of NK in limbal stem cell deficiency. So in those contact lens related keratopathy, most of the cases are partial, like sectoral. What is your experience of using nerve growth factors to treat these partial sectoral limbal stem cell deficiency?
That's a great question, and I think you're absolutely right. There's such an intricate balance between healthy epithelium and the nerves, and you need healthy nerves to have a healthy epithelium. And so when you disrupt that balance from either side, you're going to have issues. That's a great question. I haven't used Synergermin too often. Some of these treatments we use for both, right? Amniotic membrane, autologous serum. We use an NK as well as in these early limbal stem cell deficiencies. Synergermin, I think, is very reasonable to use, especially if you see that there is decline in the nerve sensation, which a lot of these patients have as well. So I think there's a lot to be studied there. What is your experience?
So I have started using regimen, and I found that if the eyes still have a good amount of stem cells, they do improve. And sometimes this improvement is permanent, meaning that kind of tip them over to the better side so that it continue to improve. But if the eyes already have severe stem cell deficiency, the effect would be very temporary. So go back to the question that you asked, what tests do you use to monitor this one? So in our center, we have a very standardized protocol imaging. First, use the fluorescein staining and look at the location and score them. And second, we use anti-segment OCT, which is really like you have in every of the corneal centers, and look at the epithelial thickness. And then last, we use the confocal microscopy to image 5 locations, central cornea and 4 regions of limbus. And often we found that in this kind of eye, they do have a good amount of stem cell remain. So the number one, exactly what you say, is to remove the contact lens, give them more growth factor, remove all the preservatives that so at this eye, and this eye often 90% or more, they can recover if you catch early enough. So
with medical treatment alone, yes.
Marcia, I wonder if you've seen this scenario. So the early ones that are picked up on exam, the patients are asymptomatic, you tell them to quit their contact because they're going to potentially go blind when they do that. The more severe ones are inflamed, and when you stop their contact, they become highly symptomatic because you have a neurotrophic effect of the contact. And so I find the more severe ones, they don't want to give up their contact and they come in and they're getting worse because they're continuing to wear their contact.
Right. That's exactly right. In fact, I had a wife of an optometrist who her husband just kept putting her back into the contact lenses, and I was like, she's going blind. She has almost no limbus left. I mean, very, very severe. So it's a frustrating thing. I think scleral lenses are really at least a winner in this stage because they provide that barrier effect as well.
Great. Let's move on to our next talk. Thank you, Marjan. Okay, Dr. Carp, take it away.
All right. So as you know, I just love taking care of ocular surface tumors, and today I'm going to share with you some updates on the management of ocular surface squamous neoplasia, what's new and exciting. Here are my financial disclosures and my great group that helped me do everything that I do, my fellows, Wissam, Wendy, Sofia de Arrigonaga, and really I want to thank the San Nicola family for having me here, my first S.I.C.S.S.O meeting. It's amazing, so thank you so much, and to my great panel. So we'll start with a case. This is a case I love of masquerades, which I see all the time, a patient with episcleritis for several months, and here's this little pink area, and this could be episcleritis. The patient was treated with steroid but didn't get better. Is it infiltrative there? Is it a lymphoma? Is it an amyloid? These are common things that I'll see. Sebaceous, less common, or is it OSSN? So in order to figure out what's going on, my OCT is really what helps me so much and gives me my magical eyes. And here I see, when I scan, this thickened, hyperreflective epithelium, and that is not normal. So this is ocular surface squamous neoplasia, where you see an abrupt transition. So based on my OCT, I did my biopsies, and I want to comment that it did show intraepithelial neoplasia, and in one area where I don't see it, there's subclinical disease, and my biopsy showed neoplasia as well, and everything else was negative. I treated this patient with topical 5-fluorouracil when it's difficult to see where the edges are. You're likely not going to be able to excise. I love trying medical therapy. It works very well, as you'll hear. And in this case, you see the epithelium normalized completely. During treatment, I followed them, and I did post-treatment biopsies in this rather unusual case, which was negative, and she's been clear now for many years. So OSSN is a spectrum of disease, an umbrella term for mild dysplasia to intraepithelial dysplasia, full thickness, carcinoma in situ, and then invasive squamous cell carcinoma. And we use our clinical acumen is the best, is the first way, and then we have many other modalities. We'll focus on OCT and a few new things. So the first three risk factors for OSSN: sun, sun, and sun. And living in Florida and near South America and Central America, a lot of OSSN. So other factors are human papillomavirus, which plays a cofactor. It's still a little unclear, immunosuppression and atopy. It can look very different. Like, what does it look like? Well, it's like the many faces of Eve. It can be leukoplakic, and it can be papillary, it can be opalescent on the cornea, it can stain with rose bengal, lissamine, or toluene blue. So an exam will give us a high suspicion. A biopsy looks like what we see on OCT, thickened epithelium with an abrupt transition. So how, and many of you know of this story, how did I start using OCT for ocular surface tumors? Well, it was in 2009 when I was at Bascom Palmer. sitting in a cornea meeting when my colleague Jay Wang was talking about this new device that he had built for the tear film. And all of my tear film colleagues were all excited about how great this would be for a dry eye, but I thought, you know what, maybe this is gonna work for my tumors. And he put it in an office right near where I see patients in clinic, and I just scanned everyone, and I learned what you see. So here is a lesion you'll see a little bit later. This is what I do. I first have my fellows look for the normal epithelium, dark, thin, about 50 microns, right? 70 microns, the refractive surgeons in here. And then you trace the base of the epithelium, and your first decision is this an epithelial lesion or a subepithelial lesion? And in this case, it's epithelial, and you ask yourself, is it thickened and is it hyperreflective? Thickened, basically my studies and others, over 120 microns is highly suggestive of neoplasia. And then the transition zone, this is an abrupt transition, that's what you see with OSSN. So what do? I would say, the tradition has been surgery, and now we have what I like to call my magic potions of 5-FU, interferon, and mitomycin. How many people here have treated an OSSN with medical therapy? Okay, great, good. And then we'll talk about some new things. So my magical potions are mitomycin was the first, that's when I started here, and I called it Gota del Diablo, or Gotcha del Diablo. 5-FU is my Diablito because it's less toxic. And really my first love was interferon to treat these drops. So how do we choose? So interferons. Interferons are anti-neoplastic, antiviral medications, but they're produced by our own white cells to combat everybody who's sneezing on you near the plane in this conference center to prevent you from getting sick and getting cancers. And my story started very early in my career at Bascom Palmer in 1994 because Sharon Plow was using interferon for hepatitis. And that's how I started to think about it, that it was both an antiviral, anti-neoplastic, works against HPV, and I had a thought, well, maybe this is gonna work. This is a crazy idea, but maybe it'll work for OSSN. And at that time, it was just being injected into the uterine cervix, which we know was HPV-related disease. And I was just a lucky bug, and it worked. This is one of the first patients I injected, and how did I decide? I just made it up. They gave 3 million 3 times a week for hepatitis subcutaneously. I injected subconjunctivally. And had it ever been done? No. Did I know if it was safe? Back then, we just wrote it on a single piece of paper, like, this is what I want to try. And it luckily was approved by the IRB, and that's what I did. I continued, while it was still available, to do 3 million. Initially, I did 3 times a week. Then it's just cumbersome for everyone. So once a week or every other week. And the drops are 1 million international units 4 times a day, continuously. Unfortunately, it's currently not available in the United States nor in Europe, but that is going to be hopefully changing soon. So here is the lesion you saw the OCT on. This is back when there was interferon, and you see the epithelium normalized. Everyday drop, but very, very kind, gentle, nice, but like I try to be in life. It keeps the eye white, happy, and really no side effects of the topical drops, just minimal sometimes irritation. The injections do give you a flu-like syndrome. So hopefully soon, a big company is working on this, and it will be back on the market for everyone, both in injections and drops. 5-FU, I switched when interferon became scarce and expensive, and 5-FU is my go-to medication for OSSN. So Dr. Valor and I and Adam Abuelagala, we did a retrospective study of over 300 of my patients that I treated. It's extremely effective. It's less expensive than any other drop, and it's less toxic than mitomycin. More toxic than interferon. So it's a real bargain, and those who know me know I love a bargain. I use it 4 times a day for a week, and then 3 weeks off, 1 week on, 3 weeks off. That's what I call a cycle. I don't use punctal plugs, but I do have them do manual punctal occlusion for 30 seconds after putting in the drop, Vaseline on the skin, and steroid if they need it. SICSSO, I just want to show you there. I tell them, you have an 87% chance that I can cure you with this drop. So if you want to try it, we can do 2 cycles. I'll see you back. And if it's not working, then we got to change plans or et cetera, biopsy. Here's a patient with a large lesion that looked like a cauliflower. And this is just 1 week on, 3 weeks off. This is after 5 cycles, and the lesion's gone. If you fell asleep for a second, there's no surgery, it's drops only. My average, I tell them, is between 4 and 6 cycles to cure most lesions. This is a crazy case with a very large lesion, and I thought, well, okay, let's get the OCT. Yes, it's an OSSN. Let's try the 5FU, and this is what happens. Some lesions go away so fast. More the papillary ones, sometimes the bigger ones, they go away like magic. So that is like that in 1 cycle of 5FU. That's not usual, 4 to 6 cycles. The complications are that it can be toxic and get epitheliopathy. You get more often skin edema. Like I said, manual punctal occlusion and Vaseline. If they have herpetic disease, you need to cover them with oral acyclovir or whatever antiviral. Mitomycin was the first drug used for this. We're familiar with it. It's also cycled. I don't like mitomycin for OSSN. Have to use it for pigmented lesions. 1 week on, 3 weeks off. 1 week on, 3 weeks off. Punctal plug because it does cause stenosis. Steroid. It's unkind to the stem cell. We talked about this the other day. Dr. Holland well, it keeps him busy, let's just say that. So it's my gota del diablo. But sometimes I have to use it if for whatever reason we don't want to excise, the patient doesn't want surgery and it's not going away. Here's one that looks like an ice cream cone. I like to name them, and then it goes away with mitomycin. Very often now we're seeing that there's a pinguecula or pterygium underneath because we used to just take them all off and didn't realize, but of course that makes sense because they're sun related. And mitomycin is the gota del diablo. People do not like you when you put them on topical mitomycin, and also they can get punctal stenosis even with the plug because the plug falls out, and stem cell deficiency. So the pearls interferon is an everyday drop. It's my angel drop. It's very kind. It's not available now, but it's coming back either in drop or injection, which is very helpful because the drops don't work as well when it's in the lid or it's above. So injections I miss. I do give 5FU injections, but they don't work as well as the interferon. 5FU is cycled, mitomycin is cycled, 1 week on, 3 weeks off. And surgery works, especially if it's localized. If it's extensive, then you're going to more likely get positive margins and kill a lot of stem cells. I do a dry technique like Carol Shields has taught us, wide excision, alcohol epithelioptic, cryotherapy, double freeze, slow thaw, and close with AMT. I like it because it treats the whole surface, subclinical disease, and especially will save you and the stem cells from being damaged. The downside is that the patients have to put in the drop. They also have to get the drop, and the upper area is gravity works against. So I have the patients lean back, and you warn them that it's more difficult, and tarsal is also a more challenging location. You can use it with surgery. So if you have positive margins, we have shown that if you use 2 cycles of 5-FU or 2 months of interferon with positive margins, that decreases your recurrence rate to that of negative margins. Sometimes my plastics people, they ask me, can you try to chemo reduce this so that we don't have to take off as much? And I tell them, when we start it, you know, there's a lot of real estate on that eye that is gonna need to come off. Let's try the drops, because even if we have to operate, it's less real estate. So what's the standard of care? So I saw a lot of hands go up, which is great. When we did this survey, we looked at Ed Stone and Jim Chodesh had done this in 2003 and 2012. And we saw a nice increase from almost 60% up to 75%, 73% increase in the use of topical meds. And at this time, there was still interferon. So more and more people, over half were using interferon. There was an increase in 5-FU, and luckily there was a decrease in the use of mitomycin. So what's new in the future? So I hope that you feel that OCT is a very magical device, but you may say, I'm not really sure what it says. And we've talked about this at the other courses here, that not to fear because AI is here. And it wasn't selfish, like just because everybody texts me and says, what do you think this is? I really think this will be a good thing to have, to spit out a guidance to people. So we developed an AI deep learning algorithm with 110,000 of my OCTs, because that's what helps develop a good AI formula. And over 90% accuracy, sensitivity, and specificity to determine if something that's OSSN versus pterygium. And sometimes the algorithm is better than the experts, again, that sees things as black box, as Dr. Jalilian talked about earlier today. We don't know exactly how it figures it out. And hopefully soon, everyone will have the power of AI. So this we just published in February. Now, what if the lesion is kind of messy? Well, it's hard to know where to scan. It's a messy OCT. Is there anything else? Or it's subtle and you don't know where to scan. So I was hoping for an accurate, non-invasive way to guide optometrists, others, general ophthalmologists about whether maybe there'd be cancer on the eye. And this was the idea of Daniel Pillais, who said, you know, we'll be able to find it in the tears and all sorts of things, systemic cancers. They can detect now in the tears. It's really crazy. So he thought of looking at microRNAs, which are very short, single-stranded RNA non-coding. And actually, I didn't know anything about microRNAs. They won the Nobel Prize for discovery. And so he asked me to collect the specimens, and then he did this, where we did OSSN, pterygia, and controls. And then he did PCR and looked for microRNA, and basically with an AUC of 94%, we were able to detect whether there was cancer or no cancer. So in particular, in messy eyes, with burns, with atopy, with MNP, etc., this is a great way to try to figure out what is going on. And hopefully also soon, maybe next year, in Sardinia, I can tell you too about pigmented lesions, because we see so much PAM and complexion-associated melanosis and need to know what's going on. And then the final thing is some new therapies. This is still unknown, completely unsolved, but it's an exciting idea. This is a patient of mine, my first patient, that had this conjunctival papilloma, which you see this undulating OCT here, and that's classic for papilloma. She was an amputee, HIV positive, had HSVK. She didn't want surgeries. She's had bad experiences. So I said, okay, well, we can try cimetidine. Oral cimetidine, 20% of the time can work with the help of the papilloma. Papillomas are very frustrating. I think it's easier to cure cancers than papillomas. And when you cut them, they spread and they have the seeds everywhere and they come back. So I tried that. She didn't like it. I tried topical 5-FU. She had HSV. She got an abrasion. So I was frustrated. She was frustrated. She didn't want surgery. So what am I going to do? As usual, I like to borrow, whether it's from my sister or whether it's from medicine. Let's borrow some ideas now from dermatology and OBGYN. And that is that they have used the Gardasil vaccine to treat other lesions like warts, condyloma, squamous. So I said to her, you want to try it? We're going to give you subcutaneously. And so I gave her 2 shots, and I was very excited that the lesion just went away. Now, it doesn't work for everybody. I've been trying it, so I'm trying to figure this out. We just opened a study in Miami. If anyone wants to fly to Miami, it's a long way. But just so you know, I'm trying to figure this out on who is a good candidate, HPV positive, not. I don't know yet, but it does work in some patients. So in summary, high-res OCT, I love it. It gives us magical powers to see what's going on. Hopefully AI and tears will also be available for everyone. I love topical medication. Surgery works, but 5-FU, mitomycin, and hopefully interferon will be back soon. Thank you to the Sarnicola family, to all of you for having me here.
Couple questions. We're running a little bit. We have time for a couple questions. Sophie, you look like you're good.
How do we get a hold of the AI?
Well, I'm working on it. We just published it, but we don't have it yet, like commercially available. I'm trying to find somebody that would be interested, either device or cloud-based. I'm not sure. Yeah.
Really amazing talk as usual. What is the algorithm when you try the topical, and at what point you try to do intralesional injection?
So intralesional was when there was interferon available. My 5-FU injections, I use 25 milligrams and half a cc, but it doesn't work as well as topical. Maybe because it's just not there enough. Topical, we do 4 times a day. So I use injection when it's 5-FU, when it's on the lid. Interferon, I love doing injections, either if they didn't want to put in the drops, or it was the lid or superior position. Otherwise, for the most part, the drops work well.
What's the role of cryotherapy as adjunct to surgery? Is it recommended?
Very important, very
every
important.
case?
Yes. So cryotherapy, as Dr. Holland is asking, decreases your chance of recurrence dramatically. And people say, oh, I don't have cryo. Well, if you have a retinal surgeon, you have cryo in the OR, and that's what I use. I just take the retinal cryo and use that. The other thing I wanted to mention is that in terms of choosing a drug, Ed and I have shared some patients that have come to Florida from Cincinnati in the winter. Interferon doesn't work as well in atopic patients. 5-FU works better in those. All right, thank you so much.
Great. Thank you, Carol. We're going to our last talk here. Dr. Jalil is going to talk about systemic therapy for severe inflammatory ocular surface disease.
Thank you to the organizers. So this will be basically a lot of the concepts are review, but just to encourage you to think more systemically when it comes to ocular surface, severe inflammatory ocular surface diseases. So just as a way of review, you know, our immune system has the innate component, which responds to injuries, to infections. These are neutrophils, or mostly these macrophages, but also we have the adaptive immune system, which are the B cells and T cells, which are much more specific, and there's memory. And so these are what we were going to be mostly targeting in a lot of these diseases. So just as a, again, overview of the agents that are available, so the corticosteroids everybody knows about, really targets every aspect of the immune system, but T-cell inhibitors, calcineurin inhibitors, cyclosporin and tacrolimus, these are effective for T-cell mediated diseases, which we'll talk about, and then these anti-proliferative agents like mycophenolate, azathioprine, methotrexate, rapamycin, these are T-cell and B-cell because they inhibit lymphocyte proliferation, so they inhibit both T-cells and B-cells. So really of these anti-metabolites, the one that I want everybody to sort of to think about if they're not comfortable with, to really get more comfortable because this really has a very good safety profile, is mycophenolate. And as you'll see, we'll go through diseases. It really has applications for many diseases, many of the inflammatory diseases which could be controlled. And really this patient, really the main need that we follow their blood counts and their metabolic panel, which initially you do a little more often, but then every few months, and this could even be done by their primary care doctor. And another agent that's useful, again, for inflammatory surface diseases are the biological therapies, particularly TNF inhibitors. So infliximab, which is an infusion, they have to go and get an infusion, or this adalimumab or Humira, which is they can self-administer. Anyway, so we'll go through the applications. And these, I rarely use these, and I never prescribe it myself. We always send them to someone else to prescribe the alkylating agents, given their high toxicity. But it's rare for us to have to use them now. So in general, it's good to think about these diseases in a spectrum. These inflammatory diseases, the spectrum on one end of the spectrum is more what we call auto-inflammatory, and on the other end is more autoimmune. And examples of, like, let's say things like PUK or scleritis, these are autoimmune, while like the inflammation that you see after chemical injury or non-Sjogren dry eyes, these are probably more auto-inflammatory. And then there are mixed, like pemphigoid, somewhere probably closer to immune, but again, there's definitely an auto-inflammatory component, chronic Stevens-Johnson syndrome, somewhere in the middle. So thinking about PUK, obviously PUK is, it's good to think about it as primarily a B-cell driven disease because it's, as best as we understand it, it's immune complex deposition. So really we have to think about how we target B cells. And really the most, obviously with our nothing works as fast as steroids. So with any condition, we need a rapid response to control it, we need steroids. Systemic steroids. After systemic steroids, probably TNF inhibitors are probably one of the most fastest acting agents that we have. So these are sort of to get more rapid response. But then more long-term for controlling the underlying disease, again, my go-to agent as the first choice for me is mycophenolate. I don't use methotrexate, but if the patient's already on methotrexate or they're managed by the rheumatologist, then they'll use that. But really, the most specific treatment, so if you have a case that's really not responding to anything, then they really need to get on rituximab, which is a highly B-cell specific CD20 target B-cell and alkylating agents. And of course, adjunctive measures to promote epithelialization, lubrication, bandage lens. And I'm not going to go into the workup much. Of course, you want to rule out an infectious if there's etiology, whether it's immune or whether it's keratitis. Anyway, moving on to another disease that really systemic therapy may become necessary are these chronic allergic diseases. So I think to this day, we still see patients with chronic allergic disease who just haven't been adequately controlled throughout the years with topical agents, and then they end up with limbal stem cell deficiency. And these are patients that, these are some examples. We published a series, I think, with Dr. Holland also. So again, chronic allergic disease is predominantly a T-cell mediated, particularly the Th2 cells. So if you're thinking systemically, then really cyclosporin or tacrolimus are going to be your best bet. I did have one patient who happened to get on, they were treated for the rheumatoid arthritis with leflunomide and had an amazing response. We published that case which in the slide just prior to this, I don't know if we can go back. Yeah, thank you. So this patient with all these changes here, these are both eyes, all of these resolved. I mean, they had been on topical steroids. I'd give them steroid injections, but these changes all reversed when they went on leflunomide. Anyway, but one thing to keep in mind in these chronic allergic diseases, more and more we're seeing dermatologists putting patients on this agent, dupilumab or Dupixent is the brand, and this and there's also an alternative, another one, I forgot the name, but this can paradoxically, in these patients with atopic skin disease or allergic skin disease, paradoxically can lead to inflammation of their surface. And I've seen some very severe inflammatory responses that have happened on the surface of the eye. So we really need to be on the lookout for those patients. And sometimes the patient may not offer you that they're on this agent and they come with a very inflamed surface, cicatricial changes. Anyway, so we've definitely had to take some patients off or treat them pretty aggressively. Going on to pemphigoid. Again, this is probably, again, as you know, it's an antibody against the basement membrane, predominantly, again, autoreactive B cells more than T cells, but really our therapy should be more on B cells. Mycophenolate, again, my go-to agent here as the first-line agent, and then for more severe cases, combination of rituximab, IVIG works quite well. Rarely, again, do we ever use alkylating agents. Corneal graft rejection, obviously well known, T-cell mediated, and acutely, of course, intense oral and topical steroids. But really, if you want the very effective way to reverse rejection is intracameral steroids. That works remarkably well. Topical T-cell inhibitors, tacrolimus, are long-term, but again, oral mycophenolate as a single agent could be quite effective for patients with high-risk keratoplasty. If you have very high-risk and multiple graft rejection, highly vascularized, then they may need this multi-drug regimen, similar to basically the Cincinnati protocol that's used for ocular surface transplant. So in summary, obviously with any of these diseases, obviously you want to rule out an underlying infection, but then once you're comfortable that this is not an infection, it's an autoimmune mediated, then your T-cell predominant diseases are chronic allergic disease, graft rejection, graft versus host, and then B-cell predominant diseases are PUK, scleritis, and pemphigoid. And that's it. Thank you so much.
Thank you. Questions?
Great talk.
Thanks.
I saw that you were saying that you give intracameral steroids for rejection.
Not routinely, but in a patient that I know is not going to be compliant or is resistant, they're on hourly steroids, they're on oral steroids, and still there's rejection is progressing. Yeah.
So intracameral. I mean, I do subtenos and topical, but I actually have not done intracameral. So you use preservative-free.
Yep, and you'll get a little white hypopion from the triamcinolone.
Yeah,
triamcinolone. Yeah.
How
often? Dexamethasone as well.
Yeah. Okay. Yeah. Or I give triescence.
So has anyone on the panel done intracameral steroid or? Yes, subtenos. Subteno, but not very
Okay.
And how often?
It works very rapidly.
I know, but how often do you inject?
Oh, no, just one injection is usually enough. Yeah.
So do you see the IOP spike when you?
I mean, they're already on. I mean, these are patients. I mean, I'm already giving them intense topical steroids. So, yeah, I mean, there could be potentially, yeah. But you can also go and wash it out if you don't like it.
Great. Well, thank you. Thank all those who stayed to the bitter end. We look forward to seeing you at this social dinner tonight.
Finita?